Good evening, everyone. Uh, Good evening, everyone. On behalf of a Global Neurosurgical Students Council, it's my great honor and a pleasure to welcome you to this a global master class in neurosurgery. Today's sessions uh, rank who gathers doctors, leaders in neurosurgery. Representing excellence in leadership, innovation, and research and clinical practice. This master class reflects this. Our mission at GNSC to connect and neurosurgical minds globally, uh, uh, and inspire the next generation of neurosurgeon. Without further delay, it's my honor to introduce our first speaker, uh, Dr. 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 Kenan is at Stanford Professor of Neurosurgery at the University of Tennessee, and globally respected leader in academic and 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 clinical neurosurgery. He is currently service head president elect of WFNS. Today he will present his lecture in titled Shaping the Future of Neurosurgery, Leadership, Innovation, and International Collaboration. Uh, Dr. Kenan, we are all proud to have you with us. The floor is yours.
Thank you very much. One more time, can you see me and can you hear me? One more time.
Yes, we can.
Okay, good. Well,
Perfect.
first of all, good morning, good evening, good afternoon to everybody who is watching. I am really honored to be talking to students because out of all my lectures that I do everywhere in the world and locally and all that, the most important is, I think, to students, because at the end of the day, the students will soon be neurosurgery residents and then neurosurgeons. And then before too long, you guys will be operating on us. You'll be operating on our backs, on our brains, on our neurological problems. So thank you for joining me. I have not chosen this lecture topic. I have been given this by Dr. Alitr. So I tried to kind of summarize my life and my philosophy and my global neurosurgery ism to this. So I'll go through this and I'll stay within 30 minutes that he gave me. So of course, I always start where I belong, where I begin, where my ancestors are, where my country is, first country, that is Sarajevo, Bosnia and Herzegovina, one of the most beautiful city in the world. And then, you know, just to share with you one of the most beautiful things that happened to me, I was deputy chairman of Winter Olympic Games Medical Committee in 1984. I just graduated medicine, and I learned so much, and I enjoyed 14 Winter Olympic Games. This is my medical school where I finished my degree, and this is my first residency, our Department of Neurosurgery. This is the new building where I go and operate every year. And then this is the Bosnian War, where I was 3.5 years surrounded by atrocities, trying to eliminate our nation from the face of the earth. And sounds familiar. And we resisted, we fought, and we are now still existing. And I'm proud to go there every year and to basically help out as much as I can. Sarajevo, where I was practicing, was surrounding by Serbian forces completely, and they had 3.5 years to shell us, bomb us, eliminate us, but fortunately, again, we survived. So this is our hospital, this is where we operated, and this is how they were shooting from surrounding hills, and this is how Sarajevo looked. Again, the history repeats itself. I landed in UMS 32 years ago, and this is the first I did skull-based fellowship and then second residency. And this is our residency team. This is at the time of Dr. Yashagil gala dinner, where he was named Neurosurgeon of the Century, and I was really honored to repeat my residency there. Tennessee is one of the states in Mid-South, and Memphis is in southwest corner on mighty Mississippi River, and I was really fortunate to get a position here. And Memphis is hotbed of music. They call it City of Three Kings, multicultural diversity, and of course there is Martin Luther King, who was assassinated there, Elvis the King, who started everything in music, of pop music, and then B.B. King, our famous soul music and father of this, and then many actors and famous people for entertaining. Some of them are patients. Our clinic department is one of the oldest in the world. This is Dr. Eustace Semps, who established it in 1921. And then this is Dr. Murphy. He was one of the first residents of Cushing. When he finished his residency with Cushing, he came to Memphis and established this department. And you see, they say United States, everything is very young. There is no history. Well, the university is 229 years old and medical school 173 years ago. And I'm obviously there for 21, 22 years now. And this is the current faculty lineup. Many neurosurgeons, leaders of WANS in the world are coming from here. I was fortunate that throughout my life, I lived in many different cities, and I still live in many different cities. Obviously, this is Sarajevo and Memphis, my two primary cities. But also, I lived in Washington, D.C., as my kids studied there, and I was almost every other weekend there. And also in Montenegro. And then as a child, I was in Sudan and Libya because my father was professor of anatomy there. So I grew up in Khartoum, and I have fond memories from there. And these are my teachers and mentors. I was really fortunate. That's God given to me. I didn't choose it. I mean, if I was able to choose it, I would choose it. But this was given to me. It came from the heavens when I came to Little Rock. These people were there. Al-Mefti, Yashagil, Ali Krish, Rick Boop, and of course, Professor Sami. I went to spend the 2 months with him back early in the 90s. And then, of course, Dr. Oliveira, a great mentor who was in Little Rock every year, and I spent a lot of time with him. I was fortunate to establish this international fellowship where 45, now I think 47 young neurosurgeons spend 1 or 2 months.
How excited you are.
About, did somebody say something?
No, I think it was a microphone malfunction.
No.
You can continue.
Okay.
No.
So I was really happy, and many of them became chairmen in their departments and prominent neurosurgeons, and probably this is my biggest achievement in addition to my kids. If we want to communicate with the world, and I'll talk a little bit at the end of my presentation, we have to have our journal. So I was really a strong supporter of idea of Dr. Oesiku to establish WFNS journal, which is now established Dr. Nandai, because we have to have our own voice, place where people will publish. One of the things that I realized early, you know, you go to different places to operate, then you have to get a special license, special, you know, permission. I decided I'm going to go the difficult way, because whenever I in my life was offered an easy way or difficult way, I learned I always choose the difficult way, because why lose time and go easy way? You just need to go tough. So I went and got all the permissions from Bosnia and Herzegovina government, Croatian government, and have an unrestricted license to practice neurosurgery there. I don't need anybody's permission. I can come anytime and leave anytime. I'm covered 100% legal. And of course, in the United States, this is my renewal of American Board of Neurosurgery diploma I received last year. And one of the other things, you know, I am a regular member of 4 societies. You can see here for many, many years. And also I'm leading international programs in Albanian society. And I'm connected with this society, with my life, with my blood, with my friendship, with my family. So I'm really proud to be the regular member. I vote in the elections and all. And in addition to that, I am honored to be a member of 5 societies, honorary member. 4 of them were in the war. So that's also something that I'm proud of. And I like global neurosurgery. I think I'm a global neurosurgery guy. I did for 20 years skull-based courses in St. Louis, in Little Rock with Dr. Christ. I go every year to Cremona, Italy now, to Dr. Fioravanti. Helped founded the Ashragil Academy, and I'm a member of many, many international societies. And one of the biggest pride is this teaching this course where I learn more than I teach in Dr. Almefti in St. Louis. And one of my fellows, who is now a very prominent German neurosurgeon, originally from Bosnia, Mirza, he put together this beautiful historic article in World Neurosurgery about this course. And then, of course, Ali Krish courses that are now becoming the norm and the best in the world. And this year, I think we have every year 4 courses. I try to participate at least in 2 every year. One of the things I teach my residents and fellows, if you are not part of neurosurgery journals, you are not going to learn how to publish, and you're not going to publish, and other people will decide about you. So get early and involved in editorial boards, learn the tricks, because this is a craft. You need to learn this. It's not just you born one morning, you create a good paper and you get to publish. You got to learn. There is a system, there is a rule, and you need to learn it. If you don't learn it, your hard work is not going to mean anything. And always I tell everybody, published in best journals. Of course, sometimes you're published in less known journals, but make sure 90% of articles are in Operative Neurosurgery, Journal of Neurosurgery, World Neurosurgery, ACTA, and others, because, you know, people read big journals mostly, and why lose time and spend weeks of your work creating a paper, and then you publish somewhere where nobody reads. You have to publish books, and I always learned that I need to publish with my fellows. You see here, this book, by the way, Dr. Gokaslan is my friend and role model. Of course, he's not my fellow, but when we split in our book, the chapters, all my chapters circled by yellow were done with my fellows. So, and then this book is with my fellow, Dr. Arnautović. He is now chairman of Department of Neurosurgery in Sarajevo. And then also with Dr. Servadei Stefini. I did just last year this book. So published with your colleagues and include your fellows and residents. So I have been early in AANS international programs because that's where I belong, as I said. And then, of course, in Albania, and even currently I served in the global program. And then in WFNS, I served probably everything. I started as a web publication committee, and then recently I was elected with president-elect. And always I'm proud, whenever I was elected, it was a margin of victory. It was never a narrow win, because I'm so thankful to my colleagues around the world that they recognize my efforts and my sincerity and my style of leadership and leading from behind. In other words, not from behind. When I say from behind, I mean not putting myself first. I always try to include my colleagues. I did a lot of work in publications, and I'm going to share with you several things, because I learned early from Dr. Almefti, you don't want to publish only for publication. You want to discover something. You want to leave behind you, you know, my Bosnian tradition says that you learn, when you leave behind you some things that people can, you know, have use. And in science is the same thing. You have to leave some, you know, discoveries, or, you know, you're not discovering genes or hot water, but you contribute a little bit. So this is one of the things that I discovered during my dissections here in Little Rock, suboccipital cavernous sinus. When I was dissecting, I noticed that this is not vertebral artery. This is a sinus around the vertebral artery. And then I cut it and discovered that it's the same as cavernous sinus. It's completely surrounded by venous structure here, you can see. And this is how it looks on the schematic diagram. And so vertebral artery and carotid artery have to pass through a venous channel, which we believe contributes to regulation of intracranial pressure and intracranial flow. Because the vertebral artery has 4 loops, it has obviously 2 rings, the same as carotid artery. And you can see here is the picture of Dr. Cavaz, and here is a picture of my article, which was honored on the cover of Journal of Neurosurgery. Exactly the same structure. You see here, our suboccipital cavernous sinus, this cavernous sinus, same. And of course, we published in literature that they have similar roles and hypothesized something about it. And then, of course, everything good has already been spoken by Dr. Yashargil. This is his book from 1969, where he showed that both arteries have 4 loops and they have to be attenuated. They don't go straight in the brain. They kind of curve and attenuate their flow before they go in. And then, obviously, that's served for further publication by other authors, which I'm published. I inspired another people to publish about it. The other thing is, you know, for example, I noticed this suboccipital ligament when I was operating in the posterior fossa, and I, for the first time, published details and named it suboccipital ligament. Before it was named dural band and things. But, you know, whenever I operate, whenever I dissect, whenever I do anything, I try to learn about it. I try to read what has been said about it before in the literature, and then I try to give my own contribution. Chiari-1 malformation, I did not plan about it. I did not do any PR, but I was operating and I realized that there is certain technique that improves the quality of the symptoms and diminishes symptoms after surgery. And I accumulated many patients, several hundred, And then I discovered, for example, that what nobody else was talking, that there is increased body mass index in majority, at least of my patients. And you can see here how the patient goes from no Chiari almost to Chiari with increase of BMI, as you can see here. And this is another patient, BMI 22, BMI 32, no Chiari. And I have a lot of patients on that. I published also some things. And then I reviewed all the publications with my daughter, who is now a plastic surgeon, and she came up with all this conclusions from the big review over so many years. So we established a kind of state-of-the-art of operating of Chiari malformations. And then I developed my own technique where I tried to improve 80%, 88% of improvement and resolution to 100%. And you can see with this technique of 270 degrees decompression, we did achieve significant improvement. The results in current Chiari malformation were good, but we further improved. The same is with neurological symptoms, and same is with syringomyelia outcomes. The other thing that I was puzzled, a lot of neurosurgery skull-based meeting, they talk about preserving hearing. So you have acoustic neurinoma, you have a little bit of hearing, and everybody was talking how to preserve that little 1% hearing in the ear or 10%. But nobody's talking about improving vision in cellular and paracellular lesions. You would sometimes find it in literature, but very, very timid. So I looked into that. I published. I tried to set some rules. I looked into the blood flow of optic nerves in the chiasm and determined again with my fellows the critical compression points, which are cisternal arachnoid membrane, falciform ligament, and optic canal. And by decompression before taking out the tumor, we believe is the way to go and preserve and improve vision. And we did studies which proved that by releasing these compressions, you decrease the pressure in the optic nerve, and you increase the mobility of optic nerve. And then I created this algorithm how to preserve vision with stage two stage and 4 steps each, totally of 8 steps, how to preserve and improve. Because operating of cellular paracellular lesion is not just you go in there, operate. You have to have a system. What do you open first? What do you decompress? How do you start working around the tumor, around the optic nerves, etc. So again, I'm not going to dwell very much about you because you are mostly medical students, so you know a little bit about this anatomy, but there are 4 points that optic nerve needs to be decompressed in order to provide safe and reasonably risk-free environment in these surgeries. The other thing that I looked also, I got a nice series of hemangioblastomas, and I again involved my fellows, and these are all the publications we did over the years. And what we looked into all publication in hemangioblastomas that have been done in the world, and realized that there are some countries and some continents that publish more, meaning that there are more cases, or they publish more, or both. And we looked into this. We also looked into the difference between von Hippel-Lindau hemangioblastomas and sporadic, and discovered so many things that were not published before in the literature, differences between different location in incidence, in median age, in male-female ratio, etc. And also distribution in different locations. And we know now exactly where is the most common lesion of hemangioblastoma and less common, and what's the difference. And we kind of brought it down to perfection in terms of statistical and demographical matter. And then obviously we looked into complications, and we defined how much blood loss there is for each location, and we also defined the mortality based on literature reports, and also we published all this and contributed. The other thing is, when you operate on pituitary tumors, there are different approaches. Some do microsurgery, some do endoscopy, and then a lot of neurosurgeons argue one is better or the other is better. So what I did is try to establish operative technique where we combine. You don't need to exclude any of these two. You use both to the advantage. So we published this. We kind of went and in details analyzed our series, again with one of my residents, one of my fellows, and published this recently in Journal of Neurosurgery. The other thing I was fixated, a lot of people talk about spinal fluid leak, and this is one of the most dreaded complications in neurosurgery, because your beautiful surgery can be completely destroyed and the life of your patient jeopardized if you have spinal fluid leak. So why don't you just completely eliminate the risk of spinal fluid leak, or work towards that? So I worked on that in different locations, because in pituitary surgery, posterior fossa surgery, and spinal tumor surgery. Because, spinal fluid leak, these are all complications that can come from spinal fluid leak. So somebody says, oh, don't worry, you have 15% incidence of CSF leak, 1%, 15%, 6%. But look, people can die from that. And it's not very uncommon to have significant complications. So why don't you, with an extra step, try to eliminate? So I learned from Dr. Al-Mefti to take a little bit of fat at the beginning of surgery and just apply it in this, for example, spinal tumor. This is a big, giant craniocervical junction schwannoma. And you see here we are opening the dura. I'll just show you a couple of slides, because a couple of videos, brief videos, because for your level, just to give you a little inspiration, this is the tumor going through the foramen. This is a spinal cord. This is vertebral artery in pica. And you see here, once we open the arachnoid membrane, this is right side, you can see the tumor. And then you can see how here we open transverse foramen of C2. And then we basically, here we divide C2 nerve, because that nerve does not contribute too much to neurological outcome, and it has been involved in this tumor. The tumor has originated from this nerve, so you had to take it. So basically, this is the tumor that is ventral to the spinal cord, pretty big, globulous, and we knew that there will be a small perforator here, which we will coagulate and divide. Here you see it, and then we will take the rest of the tumor out from the foramen. But this is the elimination of CSF leak. So you close with fluoroneuralon the dura the best you can, but you cannot approximate the dural edges to avoid CSF leak only with sutures. So what you do is you incorporate these pieces of fat, and I'm still waiting for my first CSF leak in Chiari surgery, posterior fossa surgery, and also pituitary surgery. So this is postoperative picture, and obviously tumor is out. You can see the fat here, which eliminates the possibility of CSF leak. And same is with nasal surgery. We created this technique where you make like a pacifier structure, which once you remove the pituitary tumor, you push the fat in the cella, and then being pushed out, it gets stuck in the opening where we did surgery through which we did surgery. And that's very simple technique, which completely eliminates the risk of CSF leak. And this is basically the video that shows it. This is removal of the tumor through this technique, as I said, combined technique, using first the microscope and then using the endoscope. Here you can see endoscope visualization of the diaphragma celli and stalk and pituitary gland. And then at the end you can see how we craft. You see, this is opening where the tumor came out, and then we use the fat, you see, and then size it, push it in, and the way it gets stuck back, and put some 2-seal, size it, and basically eliminate the risk of CSF leak. And in about 230 cases, we're still waiting for the first CSF leak. Same as in Chiari malformation. You see, in our article that we reviewed, most of the CSF leaks were coming from, most of the complications were coming from CSF leak, pseudomeningocele, meningitis. This is all CSF leak related. So we developed again this technique in closure, where you first suture the dura with patch graft, put a little 2-seal, and then incorporate the fat tissue into this closure to obliterate the dead space and prevent the leak. It has to be very thin fat tissue, but it keeps pressure, counter pressure, and avoids leakage. Another thing that we were also interested in spinal cord tumors, because spinal cord tumors are not very rarely encountered in neurosurgery, and neurosurgeons don't have much experience with them because they see them once a year, once every 2 years. So we published this book because I noticed in the literature at that time, several years ago, when we published it, there was no contemporary book. The most recent book was 15 years ago. So we produced a guide for comprehensive management of spinal cord tumors. Again, Dr. Gokaslan, chairman of neurosurgery at Brown, a great friend, he was kind enough to agree to co-edit this book with me. The other thing that I was interested in, because it's my passion, not only publication, but to see who is publishing in the world and who is not publishing in the world. And unfortunately, what we discovered in this article that had 3 parts published several years ago is that only 30–40% of the world in neurosurgery published, and 70% do not publish. And unfortunately, that needs to be corrected, and we are correcting it by establishing a journal, because most of the publications are coming from the United States, and then about 90%, and then followed by distantly China and Japan and some other Western European countries, but largely Africa, Asia, South America are not publishing very much, and this needs to be corrected. And we granulated all this data in these 3 articles. I'm not going to dwell very much, but you'll be able to read it if you are interested to do so. This was a 10 years period from 2010 to 2020. And coming to closure, one of the things that we need to devote our time in publication is also history of neurosurgery, because the history is the teacher of the future, teacher of life, as the old Latin proverb says. And you need to look into what other people have done, give them credit, analyze their scientific contributions, because a lot of their contributions, you'll find great ideas and great inspiration in our future work. So last 2 slides, what did I learn in this incredible journey that I have gotten in neurosurgery in the past 30 years? You have to be yourself. and remain who you are, you have to have a passion. There is nothing if you don't have a passion. You have to have a passion for neurosurgery and passion for hard work. You always need to strive for an excellence, because if you strive for mediocrity, then you will never achieve excellence. And if you strive for excellence, if you even go down to very good outcome, that's good. But if you strive for very good, you'll end up with good. So you'll constantly decrease your quality. Never take a no as an answer. I never take a no. I just go around. Somebody tells me you cannot do it. I go around it and I do it. Always take a risk. There is nothing without the risk, and never give up. Take a more difficult route. I always told you about it. If you don't take a more difficult route, it will come to you anyway. So why use time to do the bypass and do something quickly? It's not going to work. As I said, get the best possible training, go to places, learn from masters, published in best possible journals, take the best possible boards. If you need some extra time to get an extra board, take it. Create the network with friends and colleagues. Be a mentor, be a friend, and take a good care of your family, friends, colleagues, and love your patients. And always, as I said, don't stay in the comfort zone, go to the growth zone, because that is the pathway for production. Thank you very much. I hope I stayed on time. I'll be happy to answer any questions.
Okay.
Hello. Thank you very much, Professor. Was an excellent and insightful lecture. We truly appreciate you sharing your expertise and experience us today. We will now open the floor for questions. Due to time limitation, we will take only 5 questions. Kindly keep your questions brief. If anyone has a question, please just raise your hand. Anushka, I think she have a question. Ziad, ask your question, please.
Okay. Again, thank you so much, Dr. Kenan, for that talk. Something you said at the very beginning piqued my interest. You said that you repeated your residency in the US after initially doing it in your home country. I wanted to ask, if you were given the choice to do that in the modern day, if you were in the position of a resident or a medical student this year, would you make that same decision, or is there something in modern neurosurgical residency that you think would have changed your mind?
So the answer is yes, because the residency I had back home was different. I think the way you practice neurosurgery in the United States, and that's based on my experience, at least at that time, is different. You approach differently you learn a lot about spine, you learn a lot about endovascular techniques, you learn a lot about functional neurosurgery, and it's really systematically covered in neurosurgery in the United States. And I think it just made me a better neurosurgeon repeating the residency. Yes, it was tough. It was very difficult. I had a family and 2 kids, and I had to go through this difficult time. I had to pass the exam. I had to get the residency. It's very difficult to get the residency in the United States because the kids that we are getting now are geniuses, publication in major journals, sport people, NFL players. I mean, it's unbelievable. But I got it, and if I could do it again, and I finished residency in the third world country, I would probably do it. But it's tough. It's hard work, a lot of hours, a lot of days and weeks and things. So the answer is very simple. Get the best possible training. You don't need to repeat the residency, but if you can get it by visiting masters, going to symposiums, watching video clips, whatever you can do, do it.
Got it. Thank you so much.
Now, Rohina.
Hello, doctor. Thank you so much for your presentation. It was really impactful, and I did learn a lot of things. I just had one question regarding the post-op CSF leak that you talked about. So you said that you use fat as a way to plug it in. So my question was, are there any side effects of using fat as a reason, or like is the fat reabsorption something that the patients go through?
And this is a smart question, and thank you for asking it. So fat is belonging to the same person, so there are no reactions, allergic reactions, inflammatory reactions. That's number one. Number two, after a time, fat gets reabsorbed, so it's gone. Once the uh, once the mucosa epithelializes, there is nothing there, and fat gets reabsorbed. And of course, you need to be judicial. When you put piece of fat, you cannot put huge, gigantic piece of fat, which can act as a tumor with compression. You have to size it and put appropriate size in it, just enough to close that, a little bit larger than the opening to close it up, not to cause any compression. But no, I did not, in 30 years I've using it, I did not have any time that I need to go back and remove the fat or have a problem with that.
Okay, thank you so much.
Dr. Abdulrahman?
Okay. Uh, thank you, Dr. Kenan. I have one question. What is the single most important skill that young medical students and trainees should start the development to become to become global leaders tomorrow?
Well, first of all, empower yourself. Computer skills, you need to be a master of computers. Of course, I'm ignorant, and that's something that I don't know very well, but learn that. Read a lot. You have to you have to excel in theory, know the anatomy, go to the anatomy lab, learn the anatomy of the central nervous system, peripheral nervous system, spine, skull, and all that. And then learn, do surgeries, assist. First, you'll start observing, then you'll start assisting, and don't think that you will operate the first day when you start scrubbing in. You'll be watching as a second assistant, and then you'll be given a little bit, and then a little bit more, a little bit more, and then you will one day you'll wake up and you are it. There is nobody behind you, in front of you. You decide about patient indication for surgery and all that. So work hard, learn, read books, read, more importantly, journal articles, learn the anatomy, because anatomy is essence of everything. As I told you, learn computer skills. And of course, you need to learn, you have to learn. I don't speak many languages. I speak only 2 or 3, but you need to learn English, of course. And if you learn some additional languages, that's a plus, because that's the way English is the way we communicate widely in the world. What else? I think this pretty much covers my recommendation.
Okay, now for Bulahan, I think. I'm so sorry if I pronounced your name not correctly.
Yes, thank you very much. It is actually pronounced correctly. Presentation. My name is Bolawan from Nigeria. So my question goes thus. I actually want to ask, in a position whereby you get to discover or devise a new surgery, and do you actually ever face any problem when you are in surgery in practicality, probably when you are working in the operating room? Do you find any difficult trying to bring all those theoretical knowledge that is devised into the operating room? And also, I want to ask is the issue of adapting very easily to the emerging technology that you mentioned, because most of us from, I guess, third world country, if we are exposed to training here, we don't really get to implement all this, or we don't really get to use all these technological tools and all. Do you think it is actually very easy to actually get to adapt, moving from that third world country to a much more larger or global scale? That's my question, sir.
Yeah, so techniques in neurosurgery, obviously it's very modern, it's rapidly evolving, and you need to learn it. But neurosurgery in itself, especially brain surgery, is very simple. In microsurgery, you really don't use a lot of technology. I mean, yes, you use microscope, but you use your brain, you use your hands, you use anatomy. Of course, you have to have microsurgical instruments and all that. But when I was watching Professor Yashagil, Professor Al-Mefti, and others, there were some ridiculous devices in the OR. Yes, monitoring and this and that, but they always relied on their knowledge of anatomy, microsurgical technique, strategy in surgery. But yes, you need to learn as much, especially in spine. This technology is involving robotic surgery, putting screws, endovascular technology is really rapidly evolving. So in neurosurgery, the techniques are very important. The new technologies are important. Again, depends what part of neurosurgery we are talking about. But at the end of the day, I believe the man and his skills for a long time will dominate the field, until sometimes where maybe we'll all be operated by computers and by robots. But I don't see it in very near future that they will take over our skills and our personal knowledge. Again, we don't know what will future bring, but we'll see.
Thank you, sir.
And now we will move with our last question from Najla.
By the way, how many participants? Do you guys know the number of people watching this? I was just curious.
Yeah, 53 or more, like that.
Okay.
Okay, good evening, everyone. Thank you so much, Professor, for the session. My question is, I'm someone who's very intrigued by medical research. So I'm from Nigeria, so it's a third world country, resources are scarce. So as a student that wants to go into research, and someone who wants to be a neurosurgeon as well, is there like any advice you can give me? Because it is a bit difficult, and as you've said, research from Africa in general is a bit scarce. So is there any advice that you can give us so that in the coming years we can make our own contributions? Thank you.
So I will answer a very simple question. I have a great friend and a great role model. His name is Dr. Nelson Oesiku, and he is from Nigeria, and he is a foreign medical graduate who came first to United Kingdom and then to America and trained like all of us international medical graduates. He became a vice chairman of the department and then chair of the department, and then he became editor of one of the biggest neurosurgery journals. So if you look at him, you are from Nigeria, it is very feasible, it can be done. He's one of the smartest people I've ever introduced or seen. He's so eloquent, he's so knowledgeable. He speaks the best English I have ever seen among any American or any other. So yes, it's possible. Hard work, a goal fulfillment, and always identify a role model like him and others whom you can follow, because nobody started this inventing genes, in their career. You start with the small steps, micro moves, and then you grow up.
Thank you, Professor.
Once again, thank you for the excellent questions. Unfortunately, due to time constraints, we will have to stop here. Thank you, Professor, for joining us today. It was an honor to have you with us.
Okay.
All right, everyone. Next up, we have Dr. Michael Lim. Oh, is he here? Can we confirm that he's here?
I am here.
Hello, Michael Lim, Dr. Michael Lim. So Dr. Michael Lim is a world-renowned neurosurgeon and scientist, and currently he's serving as the chair of Department of Neurosurgery at Stanford University. He's a board-certified neurosurgeon with extensive expertise in brain tumors and trigeminal neuralgia, and is internationally recognized for his pioneering work in cancer immunotherapy, particularly for glioblastomas. Today, we have him for immunotherapy for brain tumors. We are looking forward to join with you, Doctor. The floor is yours.
Well, thank you so much, and thank you all for inviting me. I am going to try to share my screen. Can you see my slides?
Yes.
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 Okay. And it's in presenter mode?
Yes.
Okay.
Yes.
All right. Well, good morning, everyone. As I said, it's my honor to be here, and I'm so happy to talk to you today. I'm so honored to be amongst the list of speakers that you have. And I saw that Dr. Day also is going to be speaking, and we'll be talking about her journey. And I think that we complement each other in our talk, where she has really great work too. So today, what I thought I'd talk about is immunotherapy, but because a lot of your students here, I just wanted to maybe put it in context, or immunotherapy in context as a journey. I would say that, as mentioned before, in the US, you go through college, then you go to medical school, and then you finish residency. And for some of us who are very interested in having a career as a physician scientist, we integrate research throughout our career. And I remember when I finished my time at Stanford and got my job at Johns Hopkins, and Dr. Henry Brem brought me aboard. I negotiated protected time, I had lab space, and I had personnel. And I was 34 years of age, and I was all excited because I attained my dream of becoming a physician scientist. And when I got there, I said I was going to study immunotherapy to him. But I had this moment where I was like, oh, well, what am I going to study specifically in immunotherapy? What I tell people and what I tell my students when I mentor them in the lab is that the projects that you work on now may not necessarily be as relevant when you graduate, because oftentimes there's clinical years that you have to spend in between. And for example, at Stanford, you do your research between your 4th and 5th year, and then when you finish your last two clinical years, a lot of things change. And for me, I realized that I needed to have a vision. And I think it's important when you embark and set on what I call different epochs of your career, going from residency to being a faculty member, as an example, is a different era to your career. You need to have an idea of what you want to do. And when I said I wanted to do immunotherapy, I realized that I wanted to have a program. And I wanted to have a program that was shuttling back and forth between basic science, clinical trials, and translation as the foundation to our program. And I presented this vision to Dr. Brem, and he was completely supportive. But in order to do that, I tell students, and even with my junior faculty now, you have to tread water right now. You have to be comfortable not knowing exactly what you're going to do for the I think, for the next few months, or even up to the first year. You need to, I call it, sample the currents around you to figure out what you want to do. And to give you some context, for me, I knew that I wanted to do immunotherapy, and I wanted to do immunotherapy for gliomas because, as we all know today, our therapies have had very limited impact. And as I said before, as I was trying to find my way and I was treading water, I realized that there's not one straight path, but that there are multiple branch points, and you can come back from these branch points, but it's important that you approach it with an open mind and understand that you really need to try different things before you'll find your passion. And for me, when I started the immunotherapy journey, I, of course, I went around the different labs at Hopkins and saw that they were working on things such as STAT3 or Th17 and IL-23. And in fact, I got my lab together and we published some small papers on this. But I think the most important thing to remember that, especially because there's a lot of students in this audience, is that it always comes back to patients. And you need to take care of patients as a neurosurgeon because it gives you an intimate look into the disease and how the disease progresses. And for me, this was a patient that came into my clinic. He had a brain met from kidney cancer. And he was on a clinical trial of a drug called MDX-110. And you can see there was a single spot in his brain, and I took out his lesion. And it turned out that the pathology report showed no active tumor. In fact, only immune cells. And it turned out that this person was treated with a drug called anti-PD-1. I had no idea what it was. He was one of the very first patients in the world treated with anti-PD-1. But as I watched that patient over the ensuing months, he had a complete response. He was cured of his cancer. And he had stage 4 lung cancer. And before that, anyone who has stage 4 lung cancer was going to live less than a year. Now this guy was cured. And I realized, I said, this is something that's important, and we pivoted, and I put all my resources in the lab to try to study this. And for those of you who don't know what anti-PD-1, it's a checkpoint inhibitor, and it's the second signal after a T cell binds its cognate antigen, and this second signal turns the T cells on or turns them off, and cancer turns them off. But if you block that signal, you can actually get T cells to turn on. And over the ensuing year, I saw more patients at Hopkins respond to immunotherapy. Melanoma, kidney cancer, and lung cancer notably were the ones that had some very dramatic responses when I was at Hopkins. And in fact, you can see that this New England Journal paper was published because of the amazing results that happened, not just at Hopkins, but across the country. And so I was very excited about this therapy for patients with glioblastoma. And we went back to the lab, and if you remember that paradigm I showed you, we went from a clinical observation back to the lab, and we did translational work. And Jing Zhang, when she was in my lab, gave the animals anti-PD-1 and gave it with radiation, but anti-PD-1 showed improved survival, just like they did in other preclinical models for melanoma and lung cancer. And there were even case reports of children with glioblastoma responding. So I remember being very excited about this and saying, we got to do this for glioblastoma. And initially, we didn't get traction from pharma. They were actually reticent to give us the anti-PD-1. And in fact, they told me flat out no in 2012. But then I went back in 2013, and the leadership at Bristol Myers Squibb changed, and these three individuals, Vlad Chorich, Karina Tate, and Robert Latek, said, we want to do this for glioblastoma. And I thought they were going to give me the drug for a phase 1 trial, but instead they said, we'll go ahead and we're going to do phase 3 clinical trials. And just for you to get an idea, this was 2010 when I saw the patient, 2012 when we finished the basic science paper, and now we're here at 2014, and we're embarking on another chapter in this journey where we ran a phase 3 trial. The first phase was in first-time recurrent glioblastoma, and the second phase was in the newly diagnosed glioblastoma settings. And I remember going to New York, and we assembled a group of people. I was sitting with folks such as David Reardon and John Sampson and Antonio Moro, and we put together a phase 3 clinical trial. And fast forward 8 years later, after all 3 clinical trials were finished, and unfortunately, with these large clinical trials, it didn't work. And it was something that was really disappointing to me because other cancers were getting great responses. For example, I had neck cancers, Merkel cell, and our patients with glioblastoma didn't have any benefit. And I remember being very devastated by these results because I thought it was going to work. And so you can see this was a 12-year journey. And so again, I think as our previous speaker mentioned, you need to have resilience as a clinician and as a neurosurgeon. And when you looked back at what we learned over the 10 to 12 years at that point in time, with our experience with immunotherapy, we realized that the immune microenvironment was very different. And the immune microenvironment of glioblastoma was not the same as melanoma, and we need to understand why. So we went back to the laboratory, and Magda Polancic, who was my postdoc, went back and identified the T cells. And when she started looking at it, she said, guess what? These T cells are expressing LAG3 and TIM3. And in parallel, my colleague, Dr. Peter Fetchy, was also found the same thing. And in fact, I think their paper was quite beautiful. They showed that these T cells were indeed exhausted, like what we saw, because they were expressing LAG3 and TIM3. And so we went back and tried to understand this question of exhaustion. And one of the first things we did was, again, you work in a lab and you bring great people in. And some of my students actually looked at them and said, hey, these T cells from glioblastoma look smaller than the T cells from the periphery when we looked at it under electron microscopy. And in fact, I kind of made it, one of my students said, it looks like a raisin compared to a grape. And so these exhausted T cells are smaller and they're shriveled. Maybe there's something else going on than just a genetic switch. And so exhaustion is this phenomenon when T cells are chronically stimulated that they lose their ability to kill. And so we wanted to understand the mechanism behind exhaustion and which cells were driving the exhaustion, and is this exhaustion permanent? And this is the next step in our journey. So Chris Jackson, John Choi, and Ayush Pant, who were, Chris was a postdoc with me at that time, and then John and Ayush were MD, PhD students and MD students, then said, why don't we try a strategy where we go back and look at patients again, and let's take samples from patients with hot tumors, which was renal cell carcinoma and bladder cancer, and let's take T cells from cancers that are cold, like glioblastoma and prostate. And let's pull out their T cells and let's just sequence them and see what's different between them. And so what we did was we took about 7 to 8 patients with each of those tumor types, pulled out their tumors, and then did what was bulk sequencing at the time. Back in 2015 and 2016, we had some inkling that PD-1 wasn't working, and we started down this journey. And we didn't have single cell sequencing, and we didn't have AI like we did today. And we worked with the bioinformatics core at Hopkins. And in fact, when we finished the bioinformatics works, which took almost 2 years, when we compared exhausted T cell expression to non-exhausted T cells, both in the tumor and the periphery, 2 cytokines consistently were elevated. One was called metronome, and the other was CXCR6. We were scooped on the CXCR6 story, so I'll talk about the metronome story, which is the other story we did. So metronome is the cytokine, and it's actually called Meteorin-like. And this cytokine, which seemed to be consistently elevated in T cells that were exhausted, is actually a cytokine that was not described in cancer immunology, but was well described in exercise physiology. And it turns out that it's a primary cytokine involved that transitions brown fat to white fat. And if you remember that, that helps you generate heat. And it turns out that if you had knockout mice, these mice actually had very vigorous septic responses to any infection. And so that suggested that there was a link to the immune system. So the first thing we did was we went back to glioblastoma and we said, is this protein or is this cytokine elevated in glioblastomas? And sure enough, it was. And when we went back to our mouse model of glioblastoma, we saw that this cytokine was elevated in exhausted T cells. And if this cytokine was there, they were expressing less levels of something called interferon on this right, which meant that they couldn't kill. And then what we did was when we started giving the T cells in a petri dish in vitro, this metronol cytokine, the T cells became more exhausted. And if we went back and we worked with Crystal Makel at Stanford, she has a whole database of patients who were treated with CAR T cells. If you look at the patients who had negative responses to CAR T cells, this cytokine in blue was consistently elevated. So we wanted to understand what metronol was doing and how does it work to cause exhaustion. And when we went back and looked at the bulk transcriptomics, we saw that these metronol induced an energetic shift to glycolysis. What does that mean? Remember back to high school biology, when you burn sugar, it turns out that you have two ways to get energy from that. Remember, it's called ATP. If you go through glycolysis, you only get 2 ATPs, but normally cells go through oxidative phosphorylation, the Krebs cycle. And they go through the Krebs cycle, they have 36 ATPs. You can imagine it takes a lot of energy to kill a cancer cell, and a T cell requires 36 ATPs to kill a cancer cell. But if this cytokine all of a sudden transitions the cells to not be able to use their mitochondria and only generate 2 ATPs, then you can see that it's basically unplugging the battery to those T cells, and the T cells are maybe running out of energy. This is an energy problem, is what we thought. And what we did was we started embarking down this path and asking this question, is it an energy problem? And if you look in the middle diagram here, you can see a regular mitochondria in a T cell. And when they're treated with metronol, you can see the mitochondria blowing up and the cristae lose their potential. And in fact, if you look at these T cells and you give them a dye for mitochondria, in a normal T cell, these dyes are nice and tight and staying in the mitochondria, they stay red. But if you treat them with metronol, they bleed out. And again, shows that the mitochondrial membrane integrity is lost, and it's in a dose-dependent manner. And then we wanted to show not only phenotypically that it's changed, we wanted to show that the mitochondria are really not working right. And what happens is when the mitochondria aren't working right, they lose or spill out their reactive oxygen species into the cytoplasm. And you can see that as you give more metronol, the reactive oxygen species concentration in the mitochondria is lost. We then did something called a seahorse assay, and I'm not going to go into that today, but it's a machine that can actually measure the respiration of T cells. And if you look at the maximum respiration and spare respiratory capacity, it is exactly what it means, the ability of cells to breathe and generate energy. If you treat them with the cytokine, they lose their ability to basically breathe, or the respiratory capacity is lost. If you create a knockout T cell for this, all of a sudden these T cells are able to continue breathing and they're able to generate their ATPs. And it turns out that if you expose them chronically, these CD8 cells go permanently into glycolysis and eventually die. We then got knockout metronol mice, which is important. And when you knock out the metronol, all of a sudden animals with what we call cold tumors like GL261, which is gliomas, B6 CAP, which is prostate, and colon cancer, you can see that we were able to improve survival in these animals. We then did some other work to try to see where the metronol was coming from. And it's kind of a complex experiment, but basically we took knockout mice and wild type mice, and we put metronidazole knockout T cells into the wild type mice and vice versa. And we found that the metronidazole cytokine is actually produced not only by T cells, but by other cells in the microenvironment, including what we call myeloid cells. And it turns out that when you look at how metronidazole works, we wanted to understand at a deeper level how it works when metronidazole binds to the T cells that activate something called the PPAR delta pathway. So as you can tell, we had a negative result from a phase 3 clinical trial, and it took us 12 years to do that journey. We then went back to the laboratory and said, well, what is a problem? Why isn't it working in gliomas? And we saw that these T cells weren't working right. They were exhausted. They looked like shriveled raisins, if you remember. And to understand that mechanism, we said, well, how is that happening? Through transcriptomics, we saw that the cytokine metronidazole was expressed. And in the laboratory, we found that this metronidazole cytokine is expressed by macrophages and dendritic cells, as well as CD8 cells that are chronically stimulated. Once this metronidazole cytokine is there, it activates the PPAR delta pathway and then dysregulates the mitochondria and knocks out the energy. So at the end, we realized that it's an energy problem. And we realized that metabolism probably drives the phenotypes of immune cells. And when we had that finding, we really then thought, well, maybe we have to think about immunotherapy in a different way. It probably is something that that the soil or the environment that the tumor is creating is probably dictating in the phenotype of these immune cells. And the way we think about it now in the lab is that if you think about normoxia, in a normoxic condition, and cells can do oxidative phosphorylation. Well, in a hypoxic condition, I think of it like the Sahara Desert. It's acidic and hypoxic, and there's probably glycolysis that can only happen. And we hypothesized that maybe the cells that are in the immune microenvironment are influenced, or the phenotype of these cells and how they behave are influenced by being either in the Amazon rainforest or being in the Sahara Desert. And so what we started doing is we started just looking at different cells, and we looked at Tregs, and this was Ayush Pant's project. And when you look at Tregs, you remembered from biology, Tregs are T cells that actually suppress an immune response. And in fact, gliomas have lots of Tregs in them. And in fact, the subspecies of Tregs are called CCR6 Tregs in gliomas. And it turns out that if you block CCR6 in these Tregs, immune cells can wake up. We saw that CD8 cells became activated and they can divide. And if you actually create a knockout mouse for CCR6, you can actually generate improved survival. What was really neat was we saw that when we gave immunotherapy, almost 80 to 90% of mice were cured. And what's notable is the CT2A line on the right are are resistant to anti-PD-1. So to get 80% response rate was pretty dramatic. So what we did was we then asked this question, what's happening from the metabolic standpoint with these T cells, Tregs? And we saw that they were actually in glycolysis. So unlike CD8 cells, which wanted to do oxidative phosphorylation, Tregs say we love living in glycolysis. And in fact, when we started looking at Tregs, we said, well, 2 ATPs is not a lot. It turns out that they're generating a lot of, that their glycolysis is kind of an overdrive. And in fact, they're just generating a lot of CD8 cells. And so we realized that, again, maybe this acidic environment is good for suppressive cells. And so when we looked at myeloid cells, we went back, and everyone talks about myeloid cells now. They say there's an M1 and M2 phenotype. The M1 is helping to kill cancers, and M2s are helping to promote cancer. We said maybe there is something going on with these M1 and M2 phenotypes that are, again, influenced by the microenvironment. Lily Kim, working with Christina Jackson, looked at single-cell transcriptomic data from 23 GBM patients that we sequenced from Hopkins, and saw that in the immunosuppressive microglia and macrophages, there was this elevated enzyme of something called HEMOX1. And again, HEMOX1 is again affected by glycolysis and is upregulated. And she did a simple set of experiments. When she blocked HEMOX1 with zinc, it basically took suppressive macrophages, the M2s, and essentially made them M1s. The ARG is a marker of this, and you can see that when you treated with them with zinc, all of a sudden the T cells were activated and they were not suppressive. She also did this with siRNA and saw the same trend. And then when you block the HEMOX, all of a sudden you got some improved survival in these animals again. And so when she looked at the immunosuppressive myeloid cells, the M2s, she saw that, again, these MDSCs preferred glycolysis. And she did it two ways. She blocked it again with zinc and with siRNA and saw, again, the same trends. And so what she realized was that if you take an MDSC, or what we think is MDSC, like a undifferentiated macrophage, and it floats up to the tumor, if it's in a hypoxic acidic environment, it switches into glycolysis and is likely an immunosuppressive phenotype. But if you take that same cell and let it go into oxidative phosphorylation, it's more M1-like and wants to help you kill cancer. Finally, if you look at the cancer cells themselves, we always talk about the Warburg effect. We realized also in glioblastomas that the Krebs cycle is also disrupted. The glycolysis is not happening. And in fact, because the Krebs cycle is disrupted, gliomas accumulate as a byproduct glutamate. And when it accumulates glutamate in the microenvironment, it again is a byproduct of metabolism, but does bad things for patients. We realized that, again, when we got to Stanford, we're collaborating with Michelle Mange, and she had shown at that time that, in fact, neurons make synapses with tumors, and they use, not surprisingly, glutamate as their neurotransmitter. And you may have seen her paper showing that these are synaptic firing between neurons and tumor cells. And again, it's driven by glutamate. And if you block the glutamate receptor, which is the mPAR receptor, you're able to slow down tumor growth. And then Ravi Medikonda, who was working with me at Hopkins and now is a resident at Stanford, showed that maybe having glutamate sitting in the extracellular space of T cells also made them exhausted, and it was bad for the immune system. And when he showed that if you change the glutamate concentration, you can actually, through blocking this EAAT transporter, it basically vacuums the glutamate out. He was able to show that you're able to decrease the glutamate concentration, you were able to get T cells to come in, and you were able to reverse some of the immune cell exhaustion. And again, it's based on a metabolic product that is specifically the Krebs cycle that's been disrupted. So now we want to go back and we're asking an additional clinical question. We created a U19 grant, and we have a window of opportunity trial open at Harvard and here at Stanford, where we're giving patients the drug, and then we're taking them to the operating room. Vivek Butch, who's my functional neurosurgeon, is actually going to measure the electrical activity that's happening after we've disrupted glutamate, and then we're going to look at the specimens in the lab. We're also doing a phase 3 efficacy study with the GBM Agile, which is worldwide, and we're actually going to test whether or not there's improvement in survival. So in summary, what we think is happening with the immune system is that it's influenced by the environment that it's sitting in. And if you're in a normoxic environment that has oxidative phosphorylation, the immune cells will look very different than in them being in a hypoxic situation with glycolysis. And so what we think is happening is that the phenotype is dictated by this. If you have a situation where it's oxygen rich and has oxidative phosphorylation, you can have M1 macrophages, you have CD8 cells that are activated. Yet if you create a hypoxic acidic environment, these CD8 cells become exhausted, the M2 macrophages, these macrophages turn to M2, the Tregs are thriving, and the cancer cells are pumping out glutamate, which can affect cancer neuroscience. So I kind of to also really reinforce this point, energy is the currency of the tumor microenvironment. And so if you saw, this was a paper by Dr. Saha showing that you have T cells in the microenvironment. And if the T cells pass by cancer cells, they actually even have physical nanotubules that are sticking out like spider webs. They snag these T cells, change their conformation, poke themselves into the T cells and suck out the mitochondria to cause T cells to become exhausted. On the other hand, this paper that was published in Neuron showed that if you want to have healing, nerve healing, you need to inject mitochondria to promote wound healing. So it goes both ways. This paper out of Japan showed that not only do tumor cells suck out mitochondria from the CD8 cells, but they also send in damaged mitochondrial DNA into the CD8 cells to add insult to injury. And finally, with metastatic cancers, they actually even hijack mitochondria from neurons to promote the tumorigenicity. So again, it's an energy problem. So as you can see with the journeys that I've shown you, we've gone back to the lab. We got all the way through a phase 3 clinical trial, had negative results. We went back to the lab. We found and realized that the immune microenvironment for different cancers are different. And in glioblastoma, one of the major hurdles is a phenomenon called immune cell exhaustion. And we think that this exhaustion is actually a metabolic or an energy problem. And it turns out that your phenotype of these immune cells, not just CD8 cells, but all the immune cells are dictated probably, or we think, I can't say with certainty, but by the environment that they're in. If it's a hypoxic acidic environment, it creates a phenotype that promotes tumor growth by shifting glycolysis and oxidative phosphorylation accordingly. And obviously, we think that there are opportunities to modify the TMA to help. And when I acknowledge my lab, I get to work with some brilliant students. These ideas came from my students, and I feel very honored to be able to mentor them. And I have wonderful collaborators at Hopkins and Stanford that I've worked with through the years. And this is my relevant funding. So thank you for your time.
Thank you so much, Dr. Lim. This was very insightful, inspiring lecture, especially about the path, that we all have different paths and how one idea leads to another idea. So thank you so much for sharing this with us. So we will take questions now. Zaid has one question for you. Go ahead, Zaid.
First of all, thank you a lot for that. I'm actually one of the students who's hoping to be doing an observership next summer with you, so I hope to see you then. But about your talk, you mentioned like a plethora of factors that you said downregulate the activity of T cells. And you mentioned metronol at the very beginning. I wanted to ask whether, I'm sure not all of them, but whether some of these, including metronol, were T cell selective. And if that were the case, whether or not you think, or if there's published literature that supports the conclusion that they can be sort of induced or used to suppress T cells on purpose in cases of something like T cell lymphoma or leukemia. Is that a potential application, do you think?
That's a very insightful question. And yeah, we're very interested in looking at that to try to help us for situations where inflammation has gone awry. And we've done that at multiple levels. We're working on that now, but as an example, PD-L1, which is the ligand for PD-1, is what makes T cells exhausted. And we've published some data showing that we could stop vasospasm and swelling after a stroke by administering these reagents. There's a lot to learn from cancer, and you can sometimes take what they show us and repurpose it to help us fight other conditions. You're absolutely right. We think that metronol probably affects other cell populations, and we haven't identified them yet, but we know it's secreted by multiple different cells.
Okay, thank you.
Thank you, Zaid. Akmal, you can ask the question.
Thank you, Professor. I have one question, that how does the steroid use affect immunotherapy response in brain tumor to the patient?
Yeah, so steroids in general, we believe steroids probably have a negative effect for immunotherapy. David Reardon's group showed that steroids can dampen an immune response. And in fact, if you look at melanoma, the steroids probably dampen an immune response somewhere between 15 to 20%. The problem with glioblastoma is that when patients come in, oftentimes my trainees will call and we admit the patient and we give them Decadron 4Q6, which is a large dose of steroids. And then after they get their surgery, they go through chemotherapy and hyperfractionated radiation, both of which again are even more lymphopenic. And so CD4 counts can sometimes drop dramatically in these patients. And I tell people it's kind of like maybe they're not put in a situation, they're maybe already put in a situation to fail, as you mentioned. It's like taking somebody with diabetes and giving them 6 glasses of Coca-Cola and then giving them insulin and saying, why isn't your sugar dropping, right?
Thank you.
Dr. Lim, I have a question. Do we have any like great therapeutic agent for controlling tumor microenvironment right now, like with good outcomes?
That's a great question. I mean, we have tools to help us get to the tumor microenvironment. As surgeons, as an example, we have everything from Mahua catheters to delivery catheters such as convection enhanced delivery or gliadel wafers that can dissolve. But we're still in the midst of trying to figure out what cocktails we need to be able to help us get there.
Okay, thank you. Anushka have a question. Anushka, go ahead, ask.
Yeah, hello. So I had a question. So here you're saying that the currency of the cancer is energy and mostly mitochondria. So is there any way we can target like the cyclin D kinases or anything, any target on the mitochondria to for immunotherapy?
Yeah, it's a great question. But there's a lot of focus on mitochondria now, but mitochondria is good for immune cells. It's just mitochondria, and then cancers are trying to take up as much mitochondria as possible, and they take it at the cost or the detriment to the immune cells. And so it isn't as much trying to block or destroy mitochondria, but for example, Dr. Headley here at Stanford has created these mitotags, they call them. They're actually mitochondria that have a little tag on them that can go into specific cells. That is an approach that we're actively working on. And Joe Ha, who's a med student with me, is actually generating some really cool data with that now.
Sure, thanks.
Yeah.
Thank you, Dr. Lim. We will take one last question from Sarah. Go ahead.
Hi, Dr. Lim. Thank you for your insightful talk. I just wanted to know what's your opinion, or what have you seen in the research of adjuvant therapy with immunotherapy? Because I can see that, you know, with all the current immunotherapies emerging, there's always like pros and cons. But I've also read somewhere that adding on adjuvant therapies can sometimes mitigate those cons. So I just wanted to know what your opinion is in respect to your research.
Great question. Unfortunately for glioblastoma, immunotherapy hasn't really worked, so we're not sure what adjuvants to add yet. But if you look at the lung cancer world, certain chemotherapies seem to help in an adjuvant setting. And in the melanoma world, if we add focus radiation, and I showed that slide before actually, that's from my disclosure, we have the patent on that. If you give focused radiation plus immunotherapy, you actually can improve survival. It's as much as I think 20% or 17%. And so there's definitely a role for adjuvant and in a bigger picture, combination therapies.
All right, thank you so much.
Thank you so much, Dr. Lim, for your lecture and for answering our questions. It was an honor to have you here.
Thank you.
Okay, sir. So it's Pratiksha Balika here. I'm the Vice President of Global Neurosurgical Council, Students Council. I would like to invite Professor Samir K. Elbabaa. It's my honor to introduce him. He's a global leader in pediatric and fetal neurosurgery. He's the president of the Orlando Health Children's Neuroscience Institute, chief of pediatric neurosurgery at Arnold Palmer Hospital for Children, and a professor of neurosurgery at UCF and FSU College of Medicine with major international leadership roles in neuroendoscopy, with outstanding contributions to clinical care, education, and global neurosurgical leadership. Professor Elbabaa continues to shape the future of pediatric neurosurgery worldwide. Today, he will be speaking on advances in fetal and pediatric neurosurgery, from perinatal diagnosis to postnatal care. Please help me in warmly welcoming Professor Elbabaa. Hello, sir.
Hello, can you hear me well?
Yeah.
Thank you. Thank you. Can you see the slides moving?
Yes, sir.
Perfect. Well, thanks to you and your colleagues at the Global Neurosurgical Students Council for the kind invitation. As Professor Arnautović said earlier, you are the future of tomorrow, and you are the future leaders of the field, and greatly looking forward to connect with you, get to know all of you in the future, and thank you again for including me in this lecture series with outstanding esteemed faculty. So I will be sharing with you some updates on where we stand today in the fields of pediatric and fetal neurosurgery. I have no disclosures related to this talk. After an outstanding, inspiring talk from Professor Lim talk about immunotherapy for brain tumors, let's switch some gears and talk more about children and where the field of neurosurgery has been heading. As you know, neurosurgery in the past for kids used to be talk about trauma and hydrocephalus, putting shunts and doing some interventions here and there to help the kids. But now we're actually pushing the boundaries or treating conditions even before the babies are born. Whenever we deal with kids or children with, let's say, brain tumors, they can be different from the adult side, more common in the posterior fossa and suprasellar regions. And this is an exciting time, actually, for the field of pediatric neurosurgery, because I personally did my residency training over 20 years ago. I was focused on how to perform a safe operation, how to technically perform the perfect surgery for the child. Now we are, after we heard from Professor Lim, now we know better. Now we look at immunotherapy. Now we understand the molecular subgrouping for many of the tumors, and we understand, like in medulloblastomas and ependymomas, what is the molecular profile of the tumor, how this can be favorable or poor prognostic outcome separate from the surgery. We can do the most beautiful surgery for a tumor that has an unfavorable outcome. So whenever we discuss with colleagues from neuro-oncology what type of treatment we're going to do for this child, we have to think about it's not about the surgery, but also we need to understand the molecular profiling for those tumors. But whenever we deal with the conditions like brain tumors in children, we cannot do it alone. We have to partner with colleagues from neuro-oncology, radiation oncology, genetics, rehabilitation, and many other disciplines to give our kids the best outcomes possible. We do believe that patients will always receive the most beneficial care from incredibly skilled team, not only one doctor, one surgeon, all under one roof collaborating together. Whenever we deal with deeply seated tumors in children, we always obviously think about which gray matter we're traversing, which white matter we're disrupting, what ependymal services work around the disease. Specifically, we're dealing, let's say, with brain tumors. And we always talk about eloquent brain areas, speech areas, motor areas, optic pathways, motor corticospinal tracts, thalamocortical sensory tracts. And I do remember when I was a young faculty, similar to Professor Kenan Arnautović, who gave us an excellent talk earlier, he did his residency training in Little Rock with Professor Yassergo and Professor Al-Mifti. I was lucky to be a junior faculty, a junior pediatric neurosurgeon at that time. with Professor Yassergil, who used to always tell us, the whole brain is eloquent. Don't focus on some areas like the motor areas or speech areas. Think about the whole brain as a network. And anything you do for the brain, any approach you tackle to take out the difficult pathology, you should always think about that every part of the brain has some eloquence. Let's dig deeper into talk about some technology and some techniques. We always talk about the field of endoscopy in neurosurgery. But before we talk more about it, let's agree on the terminology, especially for the medical students. Endoscopy or endoscopic neurosurgery is when you basically use the working channel, the endoscope, to get the work done via instruments through the working channel. You have the field of endoscope-controlled neurosurgery when the endoscope is actually used for visualization and the instruments are working in parallel, similar to cases like transsphenoidal surgery. And we'll talk a little bit about the field of endoscope-assisted microneurosurgery, which one of the areas of interest of mine. That's when we use endoscopy whenever we perform the operation microsurgically, but the endoscope can assist with reaching areas and angles where the microscope cannot. Why is it advancing in a beautiful direction? Technically, because the endoscopes come out with different angles. 0, 30, 45, 70-degree angles can allow you to see corners that the microscope did not. Unfortunately, we live in the era of biases. We're all biased to one technique or another. I advise you, as the future neurosurgeons, to do not get stuck in one technology or one technique. Try to be not dogmatic and be diverse in your training, and go to perform an operation without getting stuck. I will use microscope or endoscope or exoscope. No, learn the anatomy, make the right surgical decision making, and use whatever technology available to you, and be the best at doing all of them. Whenever we deal with difficult pathologies, like in the pineal region in children, there are different surgical approaches to get there. Anatomy. You cannot tackle those pathologies without knowing the anatomy. Are we going supratentorial or infratentorial? Even if you go infratentorial, are you midline or paramedian? Learning the anatomy is essential, specifically for the venous anatomy, because this is where the morbidity comes from, reaching pathologies, for instance, in this area, the pineal region. And in the old days, we used to get scared of operating on children, very young children, 1 or 2 years old. The truth is, nowadays, with understanding the anatomy better and advancing the techniques, now we're able to access those deeply seated lesions in very young children or even babies under the age of 1 year by performing the safe approaches. One of the common approaches we do is the semi-sitting position to achieve areas, let's say in the pineal area. This is a 7-month-old baby who presented with pineal region tumor and severe obstructive hydrocephalus. We know that over 50% of tumors in the pineal region are germ cell tumors, so it's very important to achieve tissue diagnosis by obtaining endoscopic biopsy, but at the same time, we are doing endoscopic third-ventriculostomy to treat the hydrocephalus at the same time. In this case, we're coagulating here the capsule of the tumor and taking the biopsy out, and this confirmed it to be pineoblastoma. Then it was removed via supracerebellar infratentorial approach. This is another case, 15-year-old with a similar problem, pineal region tumor with hydrocephalus. Again, we do third ventriculostomy and endoscopic tumor biopsy. This came back as germ cell tumor, like germinoma. It melted away, disappeared with adjuvant therapy. You can see here 2 different patients, pineal, but the same condition, pineal tumor and hydrocephalus. This was treated by adjuvant therapies. This was treated with a surgical resection. So getting tissue diagnosis endoscopically can be essential. Another 16-year-old boy, headaches, upward gaze pulse. You see here a large pineal region mass. Same thing, we do endoscopic third ventriculostomy to treat the hydrocephalus by creating an stoma at the floor of third ventricle, in this case in front of the mammillary bodies. And this is a procedure we do on a weekly basis on babies and children with hydrocephalus or other indications. And after that's done, Now we put the endoscope, and now we're able to look at the mass. And now we're able to achieve a nice biopsy of the mass. And this is, in this case, it came back as a germ cell tumor. Here's the biopsy. It's important to achieve it safely with strategies, how to handle intraoperative complications. In this case, with adjuvant therapy, you can see the tumor melted away within a few weeks. How about the endoscope control technique, which is a natural transition in the learning curve for experienced surgeons from endoscopic to endoscope assisted, now endoscope controlled. This is a 14-year-old girl who had a large pineal cyst monitored conservatively, and then it got bigger, and now you can see the content became proteinaceous, suggesting of possible hemorrhage or neoplastic process in the semi-sitting position. Now we're doing endoscope controlled approach. Understanding the anatomy is key. Right tentorium, left tentorium, right thalamus, left thalamus, vein of Galen, basal vein of Rosenthal on the right side, left basal vein of Rosenthal on the left side, right side and left side. And now we see here, now we're dissecting the tumor from the veins. You can tell here, although this is a highly technical surgery, to do it without microscope and to do it purely with the endoscope visualization, what's called endoscope controlled pineal tumor surgery in the semi-sitting position. But you can tell I did not start working with this mass before I identified the anatomy. Here I'm looking at some branches coming from the internal cerebral veins after the tumor was dissected circumferentially. Now we're doing what's called bimanual dissection of this mass, and now we go after it to finalize the resection after we dissected this free from the venous anatomy. And now the tumor is removed in one block. Now we take a final look, and you can see here the anatomy has been preserved. All the venous anatomy, the posterior third ventricle, choroid plexus, roof third ventricle, right thalamus, left thalamus, and the tumor was removed completely without any edema or retraction in the cerebellar hemisphere because we used gravity and through a very small craniotomy. So how can we go from doing massive pineal tumor surgery with a microscope to working only with the endoscope to resect out this mass in the pineal region through a small craniotomy? There's a learning curve, but the most important thing is understanding the anatomy. And then with practice, with training, spending time in the lab for training, observing with mentors and experts in the field around the world, watching videos, YouTube. What you have available to you today is what I did not have as a medical student, which is all those beautiful videos and resources and encyclopedias of anatomy references and videos can really allow you to be better surgeons than us. Other areas that we focus on is also trying to do epilepsy surgery through very small openings through the brain without causing any damage. This patient, a 7-year-old child with medically intractable epilepsy, with this mass looks like ganglioma in the parahippocampal gyrus. The transtentorial approach to get to the mesial temporal lobe was described by mentors in the field like Professor Yassergul, Professor Toure from Turkey, Professor De Oliveira from Brazil, and others. But it doesn't matter reading that. What matters is you go to the lab and you practice and cadaveric workshops, those approaches before you go and help your patients. This is done via, here you see, I'm starting here with the what we call the sitting position, doing microsurgical infratentorial opening. This is the left cerebellum. Now we're opening cisterna magna to release CSF, to relax the cerebellar hemisphere. And now I'm switching from microscope to endoscope. Now I'm not sitting anymore. Now I'm standing. I bring the endoscope, and now I'm looking at the left tentorium. And for the sake of time, I'll skip these technical details, but now I am taking the tumor out through the tentorial opening. And here you can see I took the tumor out and I feel good about it. Then I put the endoscope and I found that there was an embarrassing finding that I left a large tumor residual lateral to the P2 segment of the posterior cerebral artery. Why? Because the microscope did not allow me to get to that angle lateral to the PCA. And now I'm doing the resection that's endoscope controlled. And now the tumor was completely resected. And now here you can see the dental opening. And most importantly, when we look carefully now at this patient, and when we look at the MRI, look what's happened here. The edema in the parahippocampal gyrus is all gone after we remove the tumor, and obviously the seizures improved in this patient. More difficult areas, cerebellopontine angle in children can be challenging, like in this 4-year-old child with large prepontine mass. You can see the basal artery perforators are displaced. And those are the cases here. Sometimes technology can be helpful, like in DTI tractography, to track down the corticospinal tracts to see what happened to them. And now we need to think about very important anatomy, the vascular anatomy, the vertebrals, the basilar junction, all the cranial nerves. How are we going to protect them? We go back to anatomical knowledge. In this case, we did retrosigmoid approach. I'm working here. Look at the medulla, push posteriorly, and here's the mass ventrally. And now I'm looking carefully, and you can see here the basal artery perforators are all involved in the sac of this mass. So now we go back to the basic microsurgical principles. Sharp microdissection is our friend here, and doing sharp microdissection to separate and dissect all the perforators of the basilar artery from this cystic mass, working through windows between all the cranial nerves. Now, after we finished, we bring the endoscope, and now we're looking all the cranial nerves from 5th down to 12 nerves, all the vascular and cranial nerve anatomy bilaterally in the prepontine space. Here you can see vertebro-basilar junction. This is the basilar artery with all the perforators, and now I'm looking at the contralateral internal auditory meatus. And on post-operative day 1, you can see here after 6 months how the brainstem went from being paper, almost 4 millimeter thickness. Now we can see it regained back great structure, and this patient recovered most of the deficits. This is another child a few months ago, came in with this extensive ependymoma, filling up the fourth ventricle, cerebellopontine angle. And you can see here when you go in, it looks scary. All the cranial nerves, all the vessels feeding the brainstem are all engulfed by this tumor in a 6-year-old child. We go back to the basics. Safe microsurgery, dissecting the anatomy. Then we introduce modern technology like endoscopy. And now we're putting the endoscope. After we completed the resection, now we see the internal auditory meatus is completely free. You see the 5th nerve, the 7th nerve, and 8th. We can see the 6th nerve as well. Petrosal sinus. Now we're looking at the internal auditory meatus, which was filled by the tumor with a 30-degree angle endoscope. We can see now the tumor has been resected. And now you can see here how the anatomy is regained in this area. And the brainstem is back to anatomical midline. Working with colleagues around the world is the best thing ever happened to me. Gathering data, studying techniques in the laboratory, publishing anatomical dissection papers and surgical anatomy papers with how we can apply the surgical anatomy in the lab to improving surgical techniques. This does not happen alone. You have to partner with colleagues from around the globe, publish, learn from them, and they learn from you. The field of pediatric neurosurgery is going in a beautiful direction. This baby girl, you can see she was born with a tumor occupying 60% of her brain. And with surgery at the age of 4 days, she almost died during the surgery. You can have beautiful outcomes in those kids and provide them with a cure when you partner carefully and strategically and safely with colleagues from other specialties like in pediatric, neuro-oncology, and others. The next part the second part of our talk is focused on the field of fetal neurosurgery, which is the closest to my heart. One of the common conditions we deal with worldwide in neurosurgery is spina bifida. It's a global disease, actually. Here in the United States, because of the folic acid fortification for the last 30 years, the incidence and prevalence dropped significantly, but around the world, you can see here, this remains a global disease. Why? It's because only 23% of the world countries are involved in the fortification of folic acid. Now there has been huge momentum through the Global Alliance Prevention of Spina Bifida, World Health Organization, ISPN, and many other societies are pushing now to improve the fortification. The truth is we still have a long way to go. When we talk about open spina bifida, we talk about the myelomeningocele and myeloschisis. The standard of care worldwide remains the postnatal repair, but I can tell you the momentum is pushing rapidly towards prenatal repair in many parts around the world. Why? Because there was a prospective randomized trial looked at randomizing prenatal to postnatal surgery for myelomeningocele. The results were published over 10 years ago. Looked at this trial called the MOMS trial. All of you can find it online and download the paper. What is fetal surgery for myelomeningocele? It's an innovative surgery operating 2 patients at the same time, the mother and the fetus, performed by a comprehensive multi-specialty team, keeping the mother safe while the neurosurgeon is repairing the myelomeningocele defect. Why do we do that? Because one of the common complications of this disease is the Chiari type 2 malformation or the and obstructive hydrocephalus, leading to shunts and shunt complications for the hydrocephalus. Prenatal surgery before the MOMS trial was thought to be, if we close this defect prenatally before 26 weeks of gestation, this can reverse the hindbrain herniation at the craniosacral junction, and this can lead to stopping the progression of the hydrocephalus and eventually reduce the rates of shunting for the hydrocephalus and reduce shunt complications. So the MOMS trial randomized 80 cases each, so around 160 cases, and the trial was stopped early because of favorable outcomes when it comes to fetal surgery. So the rates of shunting dropped in half, from 80 down to 40%. Most patients had hindbrain herniation or Chiari type 2 malformation improvement, but most surprisingly from the trial, the best news from the trial was that the patients who had fetal surgery walked better, and their functional level was at least 2 levels below the anatomical level. And that was actually a surprising result. Obviously, there were risks related to the mother and the fetus, and the most significant risk was preterm labor and prematurity. And around 10% of all fetus surgeries, not only in the trial, but even in my practice today, around 10% of all babies who go through fetal surgery, 1 out of 10 will deliver prematurely under 30 weeks of gestation. So the take-home message from the MOMS trial was that prenatal fetal surgery under 26 weeks of gestation can reduce rates of shunting in half, reverse the hindbrain herniation, improve the cognitive function and motor function, lower extremities, at the cost of small risk of prematurity. I have been very blessed. As soon as the MOMS trial results were published, at that time I was practicing at St. Louis University. At that time, we started the first program in the Midwest of the United States, and until I moved to Florida in 2017, we performed 60 cases. And since I moved to Florida to work with colleagues from maternal-fetal medicine to start the first and only program in the state of Florida, so far we have performed 62 repairs. And I've been blessed also to partner with many colleagues around the globe to help establishing fetal surgery programs in many countries and continents globally. What we found from the fetal surgery, it's not only about the spine. We're seeing significant impact cognitively because the brain anatomy is different. And we're seeing, although not studied prospectively, but we're seeing some benefits on the urological neurogenic bladder. Severity is better after fetal surgery. And then this came out, the ACOG, American College of Obstetrics and Gynecology, came out with this recommendation in 2017 saying that all women with pregnancies complicated by fetal myelomeningocele who meet established criteria should be counseled in an undirected fashion regarding all management options, including fetal surgery. The criteria are very strict. The karyotyping or microarray has to be normal, gestation age under 26 weeks of gestation, They need to have a Chiari type 2 malformation, and the level of the lesion has to be between T1 and S1. We get referrals almost on a weekly basis. As soon as the referral arrives, we look at the ultrasound, we get an MRI here. You can see this is a fetus the size of your hand. This fetus is only 21 weeks of gestation. You can see the Chiari malformation and the spina bifida. Amniocentesis is done by maternal fetal medicine colleagues. One of the challenges of fetal surgery is you operate on patients you've never met before. So that's why we found that 3D printing can be useful in those cases, not only for planning for the surgery, but also to counsel the parents. This is teamwork, and nothing better than teamwork in the operating room. Work with ultrasonographers, anesthesiologists, neonatologists on standby. A mother in lithotomy position, cesarean section is done, and our neurosurgery and maternal fetal medicine working together. Now you can see here the uterus is explanted. After uterus is explanted, this is around 25 weeks of gestation. Then we do mapping of the placenta and the spina bifida. We do the hysterotomy. Here we can see the myelomeningocele is exposed. Here with the microscope, here the more difficult cases, we call them myeloschisis cases. And then we introduced in 2013 the field of microneurosurgery. In every single case since 2013 have been performed microsurgery with the microscope. And this was a huge impact from Professor Yassergil, our mentor, who really pushed us to head in that direction for microsurgery, to reconstruct the spinal cord placode and dissect the dura, achieve watertight closure before closing the skin. Here, for the sake of time, I will show here some videos. This is a case of myeloschisis. You can see there's a sharp microdissection surrounding the spinal cord placode. After this is done circumferentially, while the fetus is utilized, the fetus is immobilized by placing retractors. We injected some saline like tissue expander to elevate the dura from the underlying lumbar fascia. Then I'm doing circumferential sharp elevation of the dura and myofascial flaps. The first step of the closure is reconstructing the placode. Now we're converting the flat placode into tubular placode. For the medical students, you can see here on the diagrams on the top, this is here, you can see sharp microdissection. You can see here there's irrigation. We're giving the fetus a warm environment, creating a fake environment that mimicking the amniotic fluid environment. After sharp microdissection circumferentially, now we do the reconstruction of the placode by approximating pia to pia. This is usually done with 8-0 or 10-0 suture. Now the spinal cord has been tubularized. Then we reconstruct the myofascial flaps and the dura, trying to achieve watertight closure, followed by undermining the skin circumferentially. The easy skin defects are closed primarily, like in this case, but sometimes we have to use inlay skin graft, like in this medium-sized defect, or in very wide defects, we have to do onlay grafts to reconstruct those defects. After that, the amniotic fluid is replaced. The whole surgery, the fetus is receiving anesthesia from the mother through the umbilical cord plus intramuscular anesthesia. The uterus is closed, then the return back to the cavity, abdominal cavity. And after that is done, then the abdomen is closed. The mother stays in the hospital around 4 days. Then they stay locally around the community for 2 weeks. Then they go back home and return for elective cesarean section at 37 weeks. On day 2 and day 3, we start seeing the lower extremities are moving. By day 3, usually ankle and toe movements. We push for elective cesarean section for 37 weeks. We do early functional assessments for the babies as soon as the babies are born and before leaving the hospital. And we monitor the backs. Sometimes if you're using white skin grafts, you have to do wound care. And even for small grafts, we don't do surgery at all. Just wound care alone is enough. And as the team is becoming more experienced, now you can see our closures are becoming more minimally invasive and our openings are becoming smaller and smaller. And this is where you can see the field of microneurosurgery goes from doing brain tumors in children into now putting it inside the womb inside the uterus to advance the field of fetal surgery. After we do the fetal surgery, here we can see reversal of the hindbrain herniation, the MRI. And when we looked at our first 50 cases, we found that maternal and fetal neonatal complications when compared to the mom's trial are very similar, which means that at experienced centers, you will find that the outcomes are very similar to the mom's trial, if not better, actually. Right now, our average gestational age at the time of delivery is close to 35 weeks, although the mom's trial was close to 34 weeks. Then we started studying our group risk factors associated with preterm labor. So now we're pushing our fetal surgeries around 24, 25 weeks of gestation. And there's a learning curve that we have seen it not only with our group, but other groups worldwide. As Professor Kenan said earlier, it's extremely important to publish and look at new ways. Like, for instance, the mom's trial talked about shunting. Our group started to look at endoscopic third ventriculostomy. Then I learned from Professor Ward from Boston, from his time in Uganda, about adding choroid plexus cauterization to endoscopic third ventriculostomy, that this can improve the outcomes for hydrocephalus for those patients, even with myelomeningocele. Then this took me on a journey to go to Uganda and spend time in Uganda at Children's Hospital, Cure Children's Hospital in Uganda, and learning from the best there. I went to Uganda to learn how to perform ETV CPC from the best in the field, then return back to the US and help those babies with treating the hydrocephalus after we already helped them prenatally doing the fetal surgery. And when we do the ETV CPC, we can reduce the rates of shunting. Now our rates of shunting in the range of less than 30%. And this is a recently accepted paper for publication, Journal Neurosurgery, looking at what happens to the base of the skull anatomy after we do fetal intrauterine surgery. And we found actually, one of our fellows, Heba from Egypt, found actually that if you perform fetal surgery, you can reverse the anatomy at the base of the skull, and this makes the ETV CPC more successful. So now we're going back to the anatomy and the impact, and this can improve our outcomes. And what is the future? Now, some colleagues around the world looking at fetoscopy. We're looking at making the hysterotomies of the uterus, making them much smaller. We're looking at surgical models for training, working with colleagues like Professor Diniz in Brazil, looking for anatomical models to train on how to perform the fetal surgery. Thinking outside the box, some colleagues like Professor Cavaliero from Sao Paulo now thinking about, after we establish track record of safety performing fetal surgery for myelomeningocele, let's look into other indications. Like in this case, this was published 5 years ago, looking at encephaloceles. It's important to track our outcomes prospectively, but most importantly, working with a team. You cannot do this alone. You need to partner with colleagues from other specialties, like in this case, colleagues from maternal-fetal medicine, obstetrics, gynecology, genetics, neurology, anesthesia. You have to partner with them. You need to travel and learn from others, and you need to open the door for others to come and visit you. And from all around the globe, on a monthly basis, we have 4 visiting fellows, including some medical students who come and visit us on a monthly basis to come and rotate with us and open the door for them to watch in surgery, go to the lab with us, attend some workshops, and also in the field of fetal surgery, go to other countries and help them setting up their fetal surgery programs. Like in the Middle East, we performed the first intrauterine surgery with colleagues in Dubai, and it's truly amazing to partner with colleagues in other countries. But most importantly, we need to track the children, track their motor function for many years to come. All those kids had fetal surgery. We need to track their outcomes and make sure they can retain this excellent motor function for many years to come. And in conclusion, we talked about how pediatric neurosurgery is changing and moving forward. You can see here, techniques are not enough. You need to know the anatomy. You need to partner with colleagues from other specialties, build a comprehensive team, work as a team, and always think outside the box. I showed you how pediatric neurosurgery is going from what we used to do 20 years ago into now operating on babies before birth. Now, we learned from Professor Lim on immunotherapy for brain tumors. Now we're looking at molecular profiling on how to treat brain tumors and see if the surgery should be gross total resection versus subtotal if this will not give the child a neurological deficit. The field of fetal surgery is truly moving in a beautiful direction. Many programs are opening around the globe, and this field is gaining excitement and momentum worldwide. It's very important, again, to partner with colleagues, publish, enroll your data and outcomes in national, international registries, and always learn from others and open the door for others to learn from you. Thank you so much.
Well, Dr. Samir, thank you so much for that wonderful talk. My name is Ziad. First of all, this is one of the most fascinating talks I think we have seen until today. Fetal neurosurgery in general, as a subset of pediatric neurosurgery, is such a new field, and I think lifetime of neurosurgery-wise, this is one of those subspecialties that are relatively at the beginning of its life. So it's wonderful to see its outcomes and applications. I'm opening the floor to questions if anyone has any. For time constraints, again, we will be limiting them to 5. But I would like to start with a question myself. I've been interested in fetal neurosurgery for a long time as a subspecialty, but I wanted to ask you whether or not there are currently, first of all, any recognized fellowship programs past pediatric neurosurgery that train surgeons particularly for fetal, and whether or not there is a sufficient enough patient volume for training as well as for daily focus just on fetal neurosurgery, or whether it's still just a subsection of pediatric neurosurgery.
Thank you, Ziad. Great question. As you know, spina bifida, fortunately, worldwide, the incidence and prevalence over the next 10 years, we're going to see it dropping slowly, which is very good. Why? Because fortification of folic acid efforts are happening worldwide, and the investment should be in prevention. The question is, what do we do for the cases we cannot prevent? How we can give them the best outcome possible? That's when the field of fetal surgery comes into play. Fetal surgery is not magic. It's not experiment. This is one of the few things in medicine, specifically one of the very, very few things in neurosurgery were proven scientifically in a prospective randomized trial. And this is extremely important to know that this is science. The results are clear, favorable, but there's a learning curve, which means this is not an operation should be performed in every hospital where pediatric neurosurgery is. In every country, there should be few centralized centers. In Europe as a continent, there are only few centers in the whole continent. And this is the way it should be, because this is one of the areas where you cannot do it alone as a neurosurgeon. So you have to work with colleagues from other specialties to build a team. When you build a team, you operate, you give good outcomes, you track outcomes that are not good and learn from them. So this is not an operation should be done at a center where they will do 1 or 2 or 3 cases per year. And to answer your question, there's no specific fellowship for fetal surgery. Pediatric neurosurgery is a huge field, and fetal neurosurgery is only 5% of this field. So in my practice every day, I do brain tumors, vascular malformations, hydrocephalus, spinal dystrophism, craniofacial and epilepsy surgery, and fetal surgery. It's a small part of what I do, but it requires coordination, collaboration with other specialties. So the people who do this work, they have to obviously be fellowship trained in pediatric neurosurgery, hopefully at a location where they have fetal surgery programs. Otherwise, you have to do it after you start practicing, visiting other colleagues. Every single fetal surgery I do on a monthly basis, I have international surgeons from around the globe coming in to attend this operation. And then I go travel to help them with the first surgery they do in their country. I learn from others and they learn from me. So there's no specific fellowship for this highly technical and highly specialized field.
Got you. Thank you so much. All right, now we'll take a question from Karima.
Hi, Dr. Samir. Thank you so much for this insightful session. My name is Karima Rifai. I'm a fourth-year medical student from Egypt. And I've been really interested in fetal neurosurgery since attending your session in Florence in summer 2024. And after really reading research in past papers, I've noticed that since the MOMS trial, a lot of the research direction was focused on really comparing open fetal surgery and minimally invasive fetal neurosurgery for spina bifida, specifically myelomeningocele. So I wanted to ask how really the direction of fetal neurosurgery research is headed from there.
Oh, great seeing you again, Karima. I
Thank you.
remember you from Florence. The future is beautiful. I think to answer your question, number one, we're going to look in the technical aspect. We proved right now through the MOMS trial that this is impactful, safe, and and when it's done properly, can lead to favorable outcomes. We have proven that. Obviously, there's a risk of complications, preterm labor, and prematurity, which we all understand and accept. So the MOMS trial was done with open technique. Then our group over the last over 10 years focused on the microsurgery part. Then other colleagues started looking at fetoscopy. The problem with fetoscopy right now, which I believe is the future of fetoscopy, there's still no prospective randomized trial, just looking at fetoscopy versus open. So it's not considered experimental anymore, fetoscopy. Why? Because many centers are pushing for that field. But it doesn't matter what we do for the babies. What matters is the outcomes. So now all the papers in the last 5 years are all focused on, if you perform the surgery fetoscopically, can you lead to same outcomes for the baby and track record of safety for the fetus, the baby, and the mother? Not only that, as a neurosurgeon, I'm not focused only in the first year of life. I'm focused on 10 years from now, tethered spinal cord outcomes and motor function preservation. Is it the same between fetoscopy or open? And the jury is still out, and there's a lot of research in that direction. This is the first part of the answer. The second part, out of technicality, is thinking outside the box. Now we have proven that fetus surgery is safe for the mother and the fetus with a high track record of safety. Let's think outside of spina bifida. That's why colleagues are talking about hydrocephalus, talk about encephalocele, and look at other indications. And God knows what the future will bring. You are the one who would be doing it, not us. So the future is going to be you all taking the field to better places.
Thank you so much, Doctor.
Thank you.
All right. So we have a question from Akmal.
Thank you so much, Professor. I have one question that what are the risks in the utero repair of the neural tube defect?
Can you repeat, please, Akmal?
What are the risks in the utero repair of the neural tube defect?
Absolutely. So we push the field, Akmal, towards microneurosurgery. First of all, I never thought about it. I remember when we started fetal surgery in St. Louis, and one day I called Professor Yastergill and I told him, hey, we started a program. What do you think, Professor? Then I showed him a video taken by phone of the surgery, and he said, what are you doing? Why are you not treating this fetal surgery like you treat an aneurysm or a brain tumor? This should be done with a microscope. Can you imagine? It was just a conversation. And then the whole field moved towards fetal intrauterine microneurosurgery and doing the operation with the microscope. So the steps of the operation and the risks have changed when we change the technique. So obviously when you have a flat spinal cord placode and now you're doing retubularization, or what we call reneurulation, to reestablish the cylindrical shape of the spinal cord, this has to be done meticulously with the smallest suture, like 8-0 or 10-0 suture. Similar when you bypass brain vessels is being done, and this will lead to reconstruction. What we're seeing in our data, that when you bring the spinal cord together, this years from now can have less scarring and tethering of the spinal cord, which unfortunately is underpublished in many series in fetoscopy or even open surgery. So the best answer to your question is the the reconstruction of the spinal cord plateau is safe. Our data so far is telling us not only safe long term, it can lower the risk of tethering of the spinal cord, but you should not trust me now and wait until we publish data that are 10 or 20 years out to look at long-term outcomes.
Thank you so much, Professor.
Thank you, Akmal.
All right, we have one more question from Gbolahan. Gbolahan, are you there?
Okay, thank you very much. Yes, sir. So my question is that, judging from the fact that spinal cord is one of those neural tissues, sir, do you ever considered, or have you ever encountered a situation whereby you performed surgery on a very late patient? Like, what can you say about the outcome of those surgeries, like especially those spinal cord bifidals? Have you ever can you actually talk more about the outcomes of those surgeries, judging from the fact that nervous spinal cord is a nervous tissue? Like, is there like, I hope you understand my question, sir. Sorry.
Are you asking about the outcome of
late surgeries?
Which surgery?
Of late surgeries, like probably surgeries that occurs late into childhood, something like that.
So obviously doing the operation prenatally or postnatally, operating the spinal cord, if I understand your question correctly, about the outcomes. And obviously when you operate in the spinal cord in a late fashion, let's say you do the surgery after birth postnatally, the standard of care is to do the repair as early as 48 hours after birth. If the repair is done in a delayed fashion or late fashion after birth, which I've seen it in many countries around the world because of the limited resources, this obviously will not have the best outcome similar to when it's done early. Late repairs after birth can lead to infections, scarring, and complications, if I understood your question correctly.
Yes, sir. Thank you very much, sir.
Thank you.
Well, if we have no more questions, I think we'll close this part of the session here. Again, Dr. Salman, that was a wonderful talk. Thank you so much. And
thank you for having me.
Thank you for being here. All right, so I think we can move on to the next talk.
Yes, sure. So please allow me to introduce Dr. Mahua. She is UW Health neurosurgeon and associate professor at the University of Wisconsin, specializing in brain and spinal tumors. Dr. Day has special interest in malignant tumors in eloquent areas of the brain using awake and functional mapping, stereotactic radiosurgery, and minimally invasive techniques to protect critical brain functions. She also leads an NIH-funded research and innovative treatment for malignant brain tumor. Today, she will be speaking about translational neuro-oncology from bench to bedside in malignant brain tumor. Dr. Day, we're honored to have you with us. Please have the floor.
Can you guys hear me?
Yes.
All right. Thank you very much for this invitation. And can you see my screen?
Yes, doctor.
Yes.
Like, do you see my presentation?
Yes.
Yes.
Do you see this?
Yes.
Sorry, for some reason it's sharing the whole screen and not the presentation because I can't see.
We can see the presentation now, doctor.
Okay. Well, thank you so much for this invitation. I really appreciate you guys including me. It has been a great morning. I always learn new from all my partners every time I join into this. So thank you for this honor. And since you guys are all students who are planning to go into neurosurgery, so I tailored the talk a little more towards students and how you think about your career journey when you start out early, and really how you think about being a surgeon scientist, because I think we shouldn't be a separate category. Everybody who is aspiring to be surgeon can also be surgeon scientist and really move the field, not just one patient at a time that we're operating on, but as a collective whole, we make that progress. So thank you for that. And then I have nothing to declare. Guys, so first, the main question is why be a surgeon scientist, right? And I think the main reason is whenever we think of research, we think of like PhD scientists who are creating solutions for problems. And then we think about physicians who are treating patients on a daily basis and who are being faced with problems that need more solution than what we have in our armamentarium. So I think where surgeon scientists fits seamlessly is that we recognize both the problem and we have the capacity to think of innovative solution. And I think you heard that from every single presenter who presented today, where they saw a clinical problem and they thought of it like differently and how to do it better. So that's why physician scientists are kind of positioned in that space perfectly. And nothing needs more innovation like neuro-oncology. As Dr. Lim pointed out, with decades and decades of research, we're still nowhere close to making the kind of difference that, say, lung cancer or melanoma has made in terms of overall survival and how we're pushing the boundaries of survival. So I think neuro-oncology is the field where we really need bright minds and future leaders to take up that challenge and push the field. There is a lot about neuro-oncology that's just not just the technical expertise of doing the surgery, but also to understand the complex biology of the tumor. Our PhDs are doing very good job of understanding the complex biology. Our surgeons and our oncologists who are struggling on a regular basis and how to provide better care for our patients, and the physician scientists kind of bridge that gap and try to align themselves. As you saw from Dr. Lim's talk, where his journey, he took a problem, he thought of it from different, and then started investigating at more basic molecular level as to how we can find better answers. So just a little bit of my background. I grew up in a very small town in India, and then I moved to the United States after I got married. And when I first moved here, I actually wanted to be an investment banker because my undergrad degree was actually in economics. But the biggest advice I can give you first from student and from where I am today is just be open to life. Sometimes life gives you signals and signs that you don't plan. You plan something and life has something else in store. And many times it's bigger than anything you had imagined for yourself. I started volunteering at a hospice facility, and everybody there said, oh, you should go into medicine. And one thing led to other. Here I am today. So how did my surgeon scientist path started? After I finished my neurosurgery residency, as Dr. Lim said, like the first thing is to get that job that will allow you to be a surgeon scientist, because find people who are serious about it, who are not like everybody says, yes, you should do research. But doing research is more than just your passion of doing research. It's also having the backup of a chair who believes in you, who wants to provide you with resources, with people, labs, space, time flexibility to be able to invest in your research, because clinical side will grow. Once you become a trained neurosurgeon, patients need you, that there is always the demand for the clinical side. But if you really want to grow your research side, you need people who are supportive of that vision of yours and who is willing to support you. And at that time, Dr. Nick Barbaro was the chair at Indiana University, who really saw the vision, which was really to make neuro-oncology care better than what we're doing with our patients right now. And he allowed me with the time, provided me resources, and then that led to a K-12 award, which eventually led to an NIH award. And then at that point, I moved from Indiana to University of Wisconsin, where again, Dr. Dempsey was very supportive of this model of a surgeon scientist who wants to really change how we take care of brain tumor patients. And that's where it really started. And when you think about how you want to structure a lab, what would that lab look like? There are a couple of things that goes into it. One is the scientific mission, which is really making the neuro-oncology more prognostic, where we're really changing the prognosis of our patient. But that process is a long process. In that process, also build an ecosystem of training. Not one single person cannot solve a complex problem. To solve a complex problem, you really need a team. Like I think everybody emphasize that. And the team is built by really inspiring the next generation like you all, who are really the future of neurosurgery, future of physicians, scientists, to get interested in not just neurosurgery, but the research aspect of neurosurgery. So in my lab, we really take these missions very seriously. Our mission is, yes, to publish, find better treatment for our patient, but a third mission is also training the next generation so we can move the field forward and get that pipeline going, because it may not be possible that we cure GBM in my lifetime, but if you train enough people in few lifetime, maybe we will be there. And that's how most science progress have happened over time. And as I said, it's really people who make the lab, because, you know, I always say 5 brains are better than 1 brain. If I am the only one who is thinking about a problem, I'm the only one who is thinking about a problem. But if I can inspire 10 other people to think about the same problem, no 2 people think the same way. And you put it all together, and now you have a momentum where things are going. And key to that are the students. Students are like bees. They go from like one lab to another lab. They are the one who are transferring ideas from various spaces, just like you go attend a talk here, some seminar there, and that's when your brains are firing. Like, how can I take a concept from, say, that person's talk and that person's surgical technique, and how I can answer this like complex questions. So I really believe that fostering inquisition in our younger generation, that's what really leads to not just better science, which will eventually lead to better outcome for our patient. And when you're a student, this can feel like, in grand scheme of things, I'm just a student. What can I do? You're not just a student. You are the future of this field. You guys can make big difference. I think someone said it in previous talk, never say take no for an answer. Find mentors who are willing to push you forward. Find mentors who sees something bigger in you that you are not seeing at that time. A lot of people believed in me when I didn't believe in myself for me to be where I am today. So find those kind of people. Those people are there, but focus on personal growth, national professional growth and local growth where you are. Find local mentors, find national mentor, find international mentor, and one is not a substitute for other. You can have multiple mentors. You can learn different things from different people. That's why our residencies are so long, where you operate with so many different surgeons, because everybody does things a little differently. Everybody can teach you something different, and at the end of the day you take it all and make something that's you, and that's not any one person that you learned it from. And the most important thing is be an active mentee. Don't just be a mentee who's always waiting to be told, oh, what's next, oh, what's next. Be all your mentors, they are 10 times busier than you are, because they're operating, they're seeing clinic, they're running labs, they're writing. So don't wait for them just because you didn't hear from them. Move things forward. Always approach mentors with some solution. Don't just come with problem. Here's a problem, and this is how I thought I could solve it. What do you think? That shows active learning, active involvement, versus saying, oh, here's a problem and I don't know what to do with it. So take that initiative, move that ball forward. Maybe it'll go in the right direction, maybe it'll completely miss the mark, but who hasn't failed? If you are here, you have failed many times, and you have learned how to get up after you fail and do it again. So keep doing it, and don't find categorical fit. One mentor can be great for person A, but not that great for person B. So find that organic mentor that you connect with, who invests in you, and you have something that may not be exactly what the field tells you is the right mentor, but if the right mentor is for you, then great, move with them. Don't be waiting for that one person who you think can be only on your mentoring team, who you really need. You can learn something from everybody. And this is, as neurosurgery is changing, not just here in the United States, I think it's changing globally. Work-life balance is a real thing. We want healthy students who are going to go and make the field healthier, more inclusive. So if you find if your mentor makes you feel like that you cannot achieve what they have accomplished without sacrificing your personal happiness or personal relationship, then you need a new mentor. That model of just someone who is up there and strong, that model is getting old. Try to appreciate within you, first of all the struggles that you went through to get where you are. That's what is making who you are. And there is, it's equally strong, trying something 100 times and succeeding at 101 time. That's commendable. You always don't have to be that person who just does it once and get it once. Those people are very rare. And even if they make you feel like that's how they did, I can guarantee you that's not how they did. Everybody failed, got up, and then climbed up. For me, as a surgeon, as a scientist, as a mother, I feel like this concept of work-life balance is a fake concept that's kind of being, so that there is no balance. It's all how you integrate this. Just because I come home, my patients are not like left alone. And just because I'm at work, it doesn't mean I don't care about what's going on with my son at school or anything. you can do it all, but you cannot do it all at the same time. So you have to have the system to be able to kind of parse it out, but it's never a clear-cut line that you can say, oh, this is my work, this is my life, and they never integrate. So, and the earlier you embrace that, the better it is going to be your journey. So how do you become an innovator? The innovator is align your research question with your clinical practice and use your OR as an extension of your lab. What really makes a good physician scientist is who takes patient's problem, and that's why I kind of modified the title you guys gave me from bench to bedside. It starts at bedside, actually. You see a problem at the bedside, you bring it to the lab and try to find a solution for it, and then take it back to the bedside. If you're creating a problem at the bench to solve, it's a fake problem, right? The problems are with patients who are coming here. So listen intentfully, listen what they're saying, listen what their problem is. Take those problems to the lab and then solve it in the lab and then bring it back to them, right? We can't experiment on people, but we can take people's problem, experiment in the lab, and bring the solutions back to them. So it's a full circle. So how I started, we have several projects in the lab that kind of all started with the same vein. So one of the very early problem that I thought as a neuro-oncologist who was doing a lot of surgeries for malignant brain tumors like glioblastoma, brain metastases, what I realized that the treatment for brain metastasis, people of oligo brain metastasis, people with like 1 to 4 brain mets, is not very clearly defined. If they have lots of brain mets, they're kind of very far into their diagnosis of cancer treatment. Their prognosis is not that good. If they have one symptomatic brain met, it's very clear indication that we should take it out. But then there is this group of people who are kind of in the middle, who get like 1 through 4, which we call oligo brain metastases. And these patients, the guideline on what we do to them is unclear. Sometimes we treat them with stereotactic radiosurgery, sometimes we resect some of them, sometimes we don't. And whenever we do stereotactic radiosurgery in our patients, what we realize is that local recurrence that's reported in the literature at 6 months is anywhere from 6 to 57%. That's a huge range. So more than half of the tumor that you're resecting, within 6 months, they will reoccur in the resection cavity after you treat them with radiation. Now the question that bothered me, like I did the surgery, I took out, it looked so good, and it's not a GBM, it's not a disease that's infiltrating through the whole brain. Why is this tumor coming back? What we can do to make sure that once we take a met out, it's a cure, for at least for that lesion. So there, when I was reading more about like stereotactic radiosurgery, what we realized is that whenever we're doing radiosurgery to the cavity, yes, we add some margin to the cavity, and which allows us to target bigger radiation. However, after surgery, the cavity kind of collapses, and it's not the same round shape when the met was there in place. Many times the timing of SRS radiosurgery changes because some people can come and do it on time. Other people, they think, oh, tumor's out, they don't worry about it. They take long time before we do radiation. And also literature showed that the patients who were being treated with the dosing of radiosurgery, they were also getting high risk of local nodular leptomeningeal disease. So then we hypothesized, what if we treated these lesions with radiation before we operated? And hence came the concept of preoperative radiosurgery. In animal models, people have shown that radiation works by having intact blood vessels. And when we do surgical resection, we are disrupting the blood vessel. And also the perioperative oxygen content also, which is a kind of similar talk on what Dr. Lim was saying, is the metabolic currency of a tumor, and having the correct oxygen niche is what was determining the tumor cell survival or not. So then what we did is we designed a clinical trial of doing preoperative radiosurgery before we resected the tumor. And what we what we did, since it was a phase 2 clinical trial, we enrolled 50 patients. One was to see if doing preoperative radiosurgery helped with local control at 6 months. And number 2 is when we are resecting these tumors after radiosurgery, we can really understand radiobiology of the tumor in a human that has been radiated inside the brain. So this trial really gave us good opportunity to test a very clinical hypothesis, which is, can doing preoperative radiosurgery do better local control? And also the other hand, more basic questions like how does radiation actually work inside the brain? And at the closure of the file, what we found that in this trial, we had 100% local control at 6 months. So every single lesion that was went through preoperative radiosurgery and got resected, there was no local recurrence in any of the patient, which really proved our hypothesis that if we radiate these tumors before we do surgical resection, we get much better local control. And based on our trial and several other trials, now we have a larger multi-organizational clinical trial, which is a phase 3 clinical trial, which is comparing now head-to-head of preoperative radiosurgery and postoperative radiosurgery. So this is kind of an example of how you can take a basic question, draw a hypothesis, run a small clinical trial, and prove your hypothesis. That can really change the way we treat patient and our clinical paradigm. And as a more cooler part of what, which I think like as a basic science, something we don't really get to do that often, is to see how the radiation was affecting brain tumors in patient in vivo. Since we resected all these tumors, we did genomic analysis on the tumors, both at the DNA and RNA level, to answer some of the more fundamental radiation biology questions. So first question, do tumor cells show hallmark of the DNA damage of radiation? Now a lot of literature is present on DNA damage and how that affects tumor biology, but it's all in murine model. This was the first time when we had actually radiated sample prospectively collected to investigate that question. And what we found is radiation is a hammer. So we were not expecting any surprises. And we did find that radiation causes widespread DNA damage. However, the DNA damage looked different across different primaries. So one thing was in good or bad about our trial was we did not control the trial for a single kind of primary. So we had primary from breast, lung, GI, from all different. And what we found that the radiation, although you would think radiation is a hammer, it should affect all cancers equally, it doesn't. Different cancers have different genomic signature of radiation. Again, a very cool finding. And when we looked at how it affects DNA repair gene, and we found like a lot of tumor cells that are actually repairing their DNA damage. Those are the tumors that eventually can fix their DNA damage and cause recurrence. Then we wanted to as does the SRS dosing fall off manifest in genomic signature? Again, what we found is that what we did is, like, when we took the tumor, we analyzed the center and the peripherally separately, because center gets the highest dose of radiation and the radiation kind of falls off. So we hypothesized that maybe it's the peripheral cells who are getting less dose of radiation. These are the cells that are giving rise to recurrence. That was our hypothesis. Again, we showed that at the genomic level, that periphery and center have very different signature between the two. And most of the DNA repair was happening on the periphery and not as much as the center, which again proved our hypothesis that the dosing does have significant effect on how we are treating these tumors. And then what we wanted to kind of confirm that how different is the effect of radiation on various cancer. Again, when we looked at like breast versus lung, if you look at the genomic signature of lung is very different than genomic signature in the breast. And then we also asked, we had a mixture of some of the tumors were treated with gamma knife and some of the tumors were treated with LINAC. So we also asked, was there a difference in the modality, how we treat these tumors? And again, we found this was quite interesting because we didn't think that there should be any difference between gamma knife versus LINAC, what we are using to treat. However, we did find difference in the type of modality. And what we found very interestingly is that in LINAC group, a group of antigens called cancer testis antigens that were significantly upregulated compared to gamma knife, which kind of gives us our like next hypothesis that are we going to treat different things like leptomeningeal spread and local spread differently? And again, all these entities we see as part of SRS, which is leptomeningeal disease and local failure, and they all have separate genomic signature compared to one another, and they're not all part of the same disease entity. So all of these kind of gave us a lot of basic science indication on how our clinical questions kind of drive what we're seeing in the basic biology, and how basic biology in turn is kind of helping us refine our clinical treatment. And many of these questions now we're designing further trials to answer them in patient population that we found at the genomic level. So I think in conclusion, what I would say that being a surgeon scientist, I think is the best of the both worlds. You get to make a direct clinical impact on your patient's life, and you really get to advance the field of science that helps humanity as a whole. And it's difficult. It's like doing 3 different jobs at the same time. But if you plan it properly, if you create the right team, it definitely is possible. You just have to have the passion to go for the unknown, not wait for other people to show. It's daunting because there is no pathway for every clinical, somebody has done it and now you're going to do the same thing. But this is being a physician scientist is really rewarding because no one has done it. Whatever you're going to do, that is going to set the standard for the world as a whole, which is daunting and exciting both at the same time. But as long as you're having fun with the process, I think, you guys are the future who can drive this forward. So this is my entire lab who are part of this. This is just not me. Many, many people are involved, all the way from high school students to PhDs and scientists in my lab who are part of this. And I think, like I said, you guys are the future for this. So thank you for this. I can take any questions.
Okay. Thank you how much doctor for a wonderful presentation with with your permission. Uh, he will open that discussion session now. Okay, Dr. Aisha, you can speak.
Thank you, Dr. Ray, for such an amazing lecture. I want to ask, can we combine a radiosurgery and target the mantle that Dr. Lim was talking about? Is it possible, or is some we can do in future, pursue it, combine both of
Absolutely.
them?
That's a great question. And as I showed, we did find that cancer testes antigen signature within the LINAC patients who were treated with linear accelerator. So which kind of not just gives us a hypothesis that we should combine these with immunotherapy. It also gives us a very refined way of combining. So we're not just combining any kind of radiation with immunotherapy. What we our next trial, what we are gonna do is combine more specifically linear accelerator with immunotherapy to see if we can boost the effect of that cancer testis antigen, which are immunogenic and they drive immune response. So yes, absolutely.
Thank you so much.
Okay, Dr. Akmal, you can speak.
Thank you, Professor. I have one question. That what are the biggest challenges in translating the lab research into effective cancer treatment for the patient?
Cancer is a complex disease, and also it's not a solitary single disease. Like hypertension is just one disease. It's hypertension. Cancer is like a disease that changes as we start targeting it. Like hypertension, once you treat it with antihypertensive medication, it doesn't come back and turn into something else. However, cancer, when you start treating it in one way, it changes, it morphs into something else. So it's almost like playing a game of chess with cancer, and you always have to be able to think 3 steps ahead of it, and if you want to win this game. And I think that's why we are struggling so much with cancer care, because we treat it as same as every other disease we treat, versus here you really have to be in that translational space. Think of 3 questions ahead of what cancer is going to do if you make this move.
Okay, thank you, Professor.
Okay, Doctor. I have one question. Okay. What who you believe is the biggest challenge in successfully moving is therapist from the bench to the bedside, and how can young researchers help this gap?
So so your question is, how can a young researcher help with the bench to bedside? Am I understanding the question okay?
Yes.
Yeah.
What do you what what do you believe is the biggest challenge in successfully moving therapy therapist from the bench to the bedside, and how can a young researcher help this gap?
So I think you're like, what is the biggest challenge of moving a therapy from bench to bedside, and how can a young researcher help? Is that correct?
Yes,
So
yes, correct.
I think one of the biggest, in neurosurgery, I feel like we take the smartest people in the globe. They are the ones who are interested in neurosurgery. But as surgeons, we're also very short-term gain driven, right? We operate on one patient and we look at one patient outcome, and versus translating basic science research to the bedside takes years of like basic science work. And sometimes, the passion gets you started, but is the commitment to stay in that space and keep doing experiments, even when your hypothesis is wrong, and then re-change your hypothesis and doing. So it's really a mental preparation to not believe in as much short-term goal, but as a long-term goal. Like being a physician scientist is like a 30-year plan. It's not like a 7-year plan that, oh, I'm gonna do this and then I'm gonna. So I think in terms of getting smart people involved in this is to having that mindset of wanting to push therapies from and be unhappy with what we're doing to our patients, right? What we're doing to our patients right now is good, but that's not the best. We can do better. So always have that uneasiness in you to say, like, I can do better than whatever we're doing right now. And keep pushing it from the research perspective, because these takes time. Like to develop one drug, like Dr. Lim said, he started his first trial, before he even did a trial, it was 8 years of just getting the groundwork. So I think that's the biggest challenge.
Okay. Thank you so much, Dr. T. Dr. Aisha speak.
Thank you so much for joining our session. It was a pleasure to have you here and all the participants to be part of this series. And I invite you all for our next lecture as well. And thank you once again on the behalf of Global Neurosurgical Student Council.
Thank you.